Good morning, everybody. Welcome to our seventh annual conference. I can't actually believe it's our seventh year for running this international conference. So thank you for everybody that's made that possible. I'm Michelle Moran. I am the Chief Executive of Humber Teaching NHS Foundation Trust, but also lead and support the Humber and North Yorkshire Integrated Care Board Mental Health Collaborative. And I'm also the partner representative on the Integrated Care Board as well. So it's really great to see so many of you here. I think we're obviously working up attendees and that's 70 at the moment. We're expecting about 195 people to attend today, and that's great. And we do call it international because we do have people coming from all over various European countries as well, which is part of the reason we've kept this online. We started it 7 years ago, which I actually can't believe. And it was in person, and then we've just developed it from there, really. But do keep your feedback coming, because last year we heard a lot from you. There'll be lots of time at the end. We've got a nice survey that you can fill in on the screen with the QR code as well. But we've got colleagues and folk from lots of NHS organisations. I'm not going to name them all because we'll be here all day, but also local authorities, NHS England, primary care, into the private sector as well, and as I say, international and local. So that's great. We've also got people with lived experience, which is really, really important, and carers. So today's theme, which is one of the things that we got some feedback last year, because we've tried to theme these events around a particular modality, particular condition, as it were, for want of a better description. And this year is the Foundation for Life, advancing perinatal and infant mental health. And I'm a health visitor and midwife by background, so it really interested me. I mean, I'm really interested across all the spectrums of mental health and learning disability and neurodiversity, but particularly, I suppose, perinatal health. And we've got some fantastic speakers, both this early morning, and later morning. We'll have a break about 11:50, but as always, please do stretch your legs and listen in as you do that. We're in a presentation mode, which means that we will be using the question and answer box on your screen. So please do keep the questions coming in. We've got somebody that's looking at those for me, and I'll keep an eye on them as well, because we have got a question and answer session later, which will obviously throw open the mics, but it'd be useful just to get some idea of questions as we go along. It's also fantastic to know that we're actually, as always with these conferences, launching our annual report. We've tried to coincide them for the last 7 years, and this year is no exception, where we launch our 24-25 annual report. So we will be putting links in the chat box for that. And that's a bit about demonstrating what we've done, the so what question. We come together as a collaborative, we work really closely together with our friends and colleagues around the system, but what difference have we made to people's lives? And we all do make a difference to people's lives on a day-to-day basis. So we've tried to put that down year on year in an annual report. And you can look back on the last ones as well, because they're all there available on our intranet site, but we'll be launching this year. We will close the conference just after lunch. But again, we want to hear from you about if there's anything you want to hear from us next year, because it's really important, because these things take a lot of time to plan. So please let us know if there's anything particular you would like to see next year. So going on to today, I'm going to welcome Dr. Andrew Cairns in a second, but we've also got lots of local showcasing as well. So we've got our parenting circle, we've got Well Together, lived experience videos, then a little bit around the national picture, which I think is important, and that'll be the general national picture, not just the perinatal piece. And there's a lot happening at the moment in the NHS, from the 10-year plan to all the work through, obviously, model ICBs, model regions, etc. And then we're going to end today with Professor Ruth McGovern on the public health piece. And we've got a real good span, I think, about perinatal. And we all know that the first 1,001 days are so crucial in anybody's life cycle. So enough from me, really. I think I've welcomed everybody. Hopefully folk know how to use the presenter mode, question and answer box there. Lots of time for you to do that. We want it to be as interactive as we can. I know these things are sometimes difficult now. We've all got used to them now, though. But we do want it to be a really interactive session, because it's about taking things out. So what? Because you're giving up your time on a Monday morning. We want to give it real interaction. I'm sure our speakers do as well. So I think that's it from me. I'm really interested to know what everybody is going to be chatting about today. On the 195 people that are joining, welcome. Thank you so much for taking your time to join us today in our 7th conference, as I've said. So let me pass over to our keynote speaker, Dr. Andrew Cairns. We've got a full bibliography in the paperwork that you will have been sent. But Dr. Andrew Cairns is consultant perinatal psychiatrist at Cumbria, Northumberland, Tyne and Wear, clinical director at the North East North Cumbria Perinatal Provider Collaborative, and is also psychiatric advisor to the confidential inquiry into maternal deaths. So a great knowledgeable speaker to get us started, and there'll be a question and answer session at the end of Dr. Cairns' presentation. So thank you all for joining us. More people are joining as we speak. Thank you sincerely, Dr. Andrew Cairns, for joining us, and over to you. Good morning.
Thank you very much, and delighted to be here with you all today. Thank you for asking me to come to speak. So as has been said, my background is working in perinatal psychiatry. I've been working in this field for about 18 years now, and certainly in my current post for about 13 years. But what I'm going to do today is speak particularly from the point of view of learning from the maternal deaths inquiry, focusing perhaps on some things which perinatal teams across all of England are currently working to achieve, but also identifying some areas from a commissioning point of view, perhaps things we need to be thinking about and asking perinatal teams to be involved with. Next slide, please. And next slide again. So for anybody who's not aware, the Maternal Deaths Inquiry, currently called Embrace in its iteration run by Oxford University, is actually a very old inquiry. It goes back to the 1950s, and indeed there were some regional versions of this going back to the 1930s. So it's an approach to reviewing maternal deaths and identifying learning that goes back a very long way. And mental health causes of death have always been considered, but there has been a specific themed chapter within the inquiry going back to the 1990s, and so every 3 years there's been publication of a review of all of the specifically mental health related deaths. It's important to understand that the way the inquiry works is by looking at records, obviously retrospectively, following a death being identified and passed on to the inquiry. The records are all gathered from the various organisations that have been involved: maternity, health visiting, GP, psychiatry, potentially drug and alcohol, etc. They're all anonymised, so any identifiable information is redacted. So we never really know exactly where an individual lived, so we can't be sure exactly what services they may have had access to, which is one of the slight tricky things I think about interpreting the information. But it does mean that we get to look at essentially every single woman who's died, and we have a very effective way of identifying those from national registers and coroners, etc. Next slide, please. So for anybody who's ever heard one of these talks before, this slide may be relatively familiar, and this is updated to the current data which we published in September, and it relates to the years 2021 to 2023. There's been a slight increase in the rates of suicide over that period, so it's gone up from 3.7 to 4.06 per 100,000 maternities. The rates of death due to substance misuse are broadly similar to previous years. In the bottom right, we have a pie chart which illustrates the proportions of women dying in the late period. So late maternal deaths are classed as 6 weeks up to 1 year postpartum. And this pie chart really has not substantively changed over the past 30 years or so. So the largest groups or causes of death in the late period are both mental health related, so either through suicide or substance misuse. And as you can see, when you look at those two groups, it's around a third of all late deaths. And if anything, this proportion actually has slightly gone up over the years, even though the absolute numbers of late deaths have not particularly changed. Antenatally, so during pregnancy and then up to 6 weeks postpartum, suicide remains a very important cause of maternal death. And in the most recent report, it was second only to VTE as a cause of maternal death. Next slide, please. When we think about when these deaths tend to occur, they are predominantly after childbirth. So with the suicides, we've typically seen the majority of women dying through suicide throughout the postpartum year. When we go back a couple of decades, it often used to see a drop off towards the end of that year from about 6 weeks to 6 months, to 12 months postpartum. With more recent ascertainment of cases, that has shifted, and we now see a fairly continuous rate throughout the year, which we think is due to that better ascertainment of the late cases, many of these being identified through maternity services. We had a bit of a worrying trend back in 2020, which is the little grey graph up in the top left, where we actually saw an increased rate of antenatal suicides as well, by a threefold increase, actually. That has not been borne out post-COVID, thankfully. So the rates of suicide remain relatively low antenatally compared to postnatally. Next slide, please. When we look at substance misuse deaths, again, the predominance is postpartum. Now, when we're talking about deaths by substance misuse, this can be through a number of means. One can be accidental overdose. Assessors will think quite carefully about the information presented as to whether the woman intended to take her life through use of illicit drugs or not. Those would then be classified as suicides. It can be accidental overdose. So classic scenario would be somebody has a history of opiate use, who's reduced their use during pregnancy, loses tolerance to those drugs, reverts to previous levels of use postpartum, and therefore accidentally overdoses and dies. It can also be through secondary effects of substances. We've seen a particular number of cases where women have died through cardiac arrhythmias, for example, through combinations of drugs, particularly cocaine and alcohol. There's been a number of those. In previous years, and again in the top left with a little grey graph just for comparison, we've often seen a bit of a peak between about 3 and 9 months postpartum. And the hypothesis around that, it's not possible to test this out, but the hypothesis around that is that women who have a history of substance misuse and have managed to successfully reduce their use antenatally, many of the cases that we review, their children will be placed temporarily in care postpartum. And so there's a drive to try and persevere with that abstinence in the postpartum period. As you'd imagine there, the stress of the circumstances of having a child in care, just having contact perhaps 3 or 4 times a week, the stress of family court proceedings can have an impact on relapse into substance misuse. And so that was our sort of explanation as to why we tended to see a greater proportion of deaths slightly later after childbirth. That data is slightly different for the 3 years, 21 to 23. Exactly why that is remains unclear, and I think it'll be one to watch in the next report in 2028. Next slide, please. A few years ago, we were particularly concerned about increasing rates of teenage mums who are dying through suicide. Now, the absolute numbers are not great, but the rates were a particular concern. Historically, we used to see perhaps 2 or 3 teenage mums dying through suicide over a 3-year period. And as you can see there, rates from 2014 to 2016 was about 2.5 per 100,000 maternities. Pre-COVID, for the years 2017 to 19, that rate went up to 11 in 100,000. And then for the first year of COVID alone in 2020, we saw a further increase up to 27 per 100,000. So essentially a tenfold increase on the baseline rate that we'd seen previously. And to put that in some comparison, looking at Office for National Statistics data for the same year of a relatively similar age range, for women who just from the general population, the baseline rate was about 2.5 per 100,000, so that old historical sort of level. In the most recent triennial period, we've seen the rates drop back, which is obviously a good thing, but not yet necessarily to the baseline level. So I think this is something that we need to be thinking about. All of the women's that were reviewed, particularly think about that 2020 year, all of these young mums had really complex backgrounds. They'd been involved with social care in their own right, mental health difficulties, history of abuse, often substance misuse issues. So really vulnerable young women who really required a multi-agency approach. And I think this is a potential challenge for us working in this area about how we can work together across different organisations to engage these women, to develop safety plans and help them address the many complex factors that underlie their risk. Next slide, please. This sadly is a slide that hasn't really changed at all over the last few decades and does not make nice reading, I'm afraid, in terms of the mode of death which we're talking about. What we've found over many years is that the suicides typically are violent. The majority of women consistently dying through hangings. And in the most recent inquiry, that was around 2/3 of all deaths, but it's consistently over 50%. And also through other violent means, train tracks, jumping from heights, with overdoses being a relatively small proportion of the deaths. Historically, this has been seen to be a bit of an outlier in contrast to suicide in women generally in the population, although again, ONS data suggests that the rates of violent death in younger women is approximating these sorts of levels. So we're seeing a general trend in that direction. I think the other thing that we very much would take away from this is that, of course, this is a situation in which there is no second chances. When somebody has taken an overdose of medication, often there's an opportunity then, a window of time in which we can seek medical treatment and hopefully address that risk that they have. With violent modes of death, that's highly unlikely. So it's really important that we're taking any thoughts or attempts of this sort extremely seriously. Next slide, please. And that leads us neatly into the red flags, which were published a few years ago now, back in the 2015 report. And this related to a series of cases where the women all had severe mental illness, particularly severe depressive and psychotic illnesses. This vignette is of a woman who died violently. She was in her 30s, 2 months following the birth of her first baby, no prior psychiatric history, and developed what seemed to be a rapid onset of anxiety and depressive symptoms just a couple of weeks after giving birth. She had quite marked preoccupations about the baby's health and thoughts about her being inadequate as a mother. And there had been some self-harm, and she was described as being guarded in most assessments. So for those of us working in mental health services, often we would recognise that feature of a guarded presentation, often as being associated with illnesses such as psychosis. Mother and baby unit psychiatric admission was considered but was declined, and she was under the care of a crisis home-based treatment team. And what this case really reflects is what's common with certainly puerperal psychosis, which is a rapid deterioration in presentation, often featuring thoughts, potentially acts of violent self-harm. And in each of these cases, we saw a pattern of sort of preoccupation about not being good enough as a mother or incompetency, where there was no prior history to suggest that was a concern. It was not something that had been worried about during antenatal visits, for example. This also sometimes comes up in cases where we've got an individual who's got quite a complex background of trauma history. So for those adults who've had particularly difficulties in their early life with experiences of parental neglect or abuse, they can not infrequently have worries about whether they're going to be able to parent. That's a different type of presentation from this, and one that still needs to be taken seriously. But the red flags are focusing very much on this group where there's no prior reason to suspect that that's likely to be a problem. Next slide, please. And that's just summarizing the same thing. We'll move on to the next slide. It's been well recognised for quite a number of years that there are groups of women where we can quite effectively predict the risk of relapse postpartum, and this relates to what we call the amber flags, which again were published back in the 2018 report. In this case, vignette is of again a woman in her late 30s who died violently in late pregnancy. She'd had previous mother and baby unit admission after her first child was born and had an existing diagnosis of bipolar affective disorder. She'd required inpatient care after the birth of her second child. She was discharged from mental health care 2 months before her last pregnancy, and unfortunately the discharge letter made no mention of future perinatal risk, though her diagnosis was well identified and noted at booking of the next pregnancy. The plan that was suggested was that she could see her GP if there was any deterioration in mood. And given what we know about the rapid deterioration of these cases postpartum, that approach was entirely inappropriate, particularly with conditions such as bipolar type 1. The rate of relapse without treatment is exceedingly high, somewhere around 1 in 3 to 1 in 2. Next slide, please. So it's important that we note history of particularly psychotic illnesses and bipolar illnesses and recognise their elevated risk. And this is what perinatal teams are really very good at, identifying these women, ensuring that we offer close monitoring. If there's family history, then that in isolation of an individual history, I think is something that often we would encourage maternity services to monitor in the first instance, because the rate of relapse in those cases is somewhat lower, but still significantly elevated above the baseline, so around 1 in 20, where there's solely a family history alone. Next slide, please. Another way of identifying this risk, I think this graph really beautifully illustrates some of the differences between different mental health conditions and risk of relapse. So in this graph, what we've got is a red line showing the cumulative increase in relapses of women with a diagnosis of bipolar disorder. And you can see that really rapid rise up in the early 3 to 4 weeks postpartum. The blue line below it relates to women who have schizophrenia-like psychotic illnesses, and again, quite a substantial increase in relapse through the postpartum year. Both of those lines significantly separating from all of the rest. And then along at the bottom, the sort of multicoloured group of lines representing other psychiatric conditions. Now, what we think is going on here is that with bipolar illnesses, there seems to be a particular biological trigger in relation to childbirth that causes that really dramatic rate of relapse in the early couple of weeks postpartum. With schizophrenia, you don't see quite such a steep increase in the early postpartum weeks, and just more of a gradual incremental rise throughout the year. And we view that as being related to more of a stress-induced effect with schizophrenia-like illnesses rather than the sort of direct biological effect of childbirth on bipolar disorders. So both conditions significantly increased with a risk of relapse, and a really good opportunity. Although these figures, 1 in 3, 1 in 2 risk of relapse are very scary numbers to be hearing, because they're such well-defined timeframes, we can very effectively offer interventions to monitor, offer prophylactic medication, and get women the care they need, admission, to address any signs of relapse rapidly and keep them and their babies safe. Next slide, please. Another way of illustrating this bipolar deterioration pattern is this lovely study. It's quite old now, back in 2000, and it looked at rates of relapse in women who had discontinued lithium. Now, some of you may be aware that discontinuation of lithium, particularly abruptly, is often associated with high rates of relapse of bipolar disorder. And indeed, if you look at the middle graph in this chart, what that shows is around 50 to 60% of women discontinuing lithium, either in non-pregnancy or in pregnancy over 40 weeks, became unwell. The graph to the right then looks at the weeks postpartum, and you can then see a really dramatic separation between the two groups. So again, a non-pregnant comparison group continue to deteriorate if they've discontinued lithium, but nothing like at the rate of those women who've recently given birth, just really illustrating that this is a particularly risky time for relapse of bipolar disorder. Next slide, please. We've been really fortunate in England to see a dramatic improvement in access to perinatal mental health services. So following the investment that was announced back in 2015, we've been able to open a number of new mother and baby units. So there's 4 new units were opened initially. There's another new unit opening soon in Chester, and a further ward in addition to the existing one in Leeds is due to be coming online soon. And perinatal community teams that were previously very reserved to particular areas of the country, often surrounding a location of a mother and baby unit, are now widely available across the UK. Unfortunately, one of the consequences of this is that we're now seeing increasing numbers of women who've died through either suicide or substance misuse who've had access to these services. And I think that just really reflects the increased availability of the services. But just obviously identifies that potentially these services are going to be working with women, and gives us an opportunity to be trying and addressing and avoiding these adverse outcomes. Next slide. Thinking about some of the more tricky cases, perhaps, and areas where there may be question about the appropriateness of involvement of perinatal teams. I'm just going to take you through this vignette first. So in this case, a young woman had requested a termination of pregnancy. This was her 5th pregnancy. She had a number of social risk factors and known mental health problems, including labels or diagnoses of PTSD, substance misuse. She had a history of self-harm and chronic suicidal ideation. She'd had 4 previous C-section births and 3 living children who were in her care. Due to her obstetric history, her GP referred her to secondary care, and an appointment with termination was scheduled 6 weeks later. Whilst awaiting this appointment, she was assessed by a community mental health team who advised her to self-refer to talking therapies. She missed her appointment for the termination as she did not have the funds necessary for transport. A new appointment was made, but she faced further delays due to the uncertainty around which service was going to be responsible for facilitating the transport and specialist availability. In light of her continuing pregnancy, a safeguarding review was conducted by Children's Services. A week later, she had the termination, but the day after the termination, she was referred to the CMHT due to stress and worsening mental health, and she died by overdose 2 days later. I think one of the challenges with these cases is often which service do they best fit into. So initially, clearly she was pregnant, but she was considering a termination, and it's not unusual for there to be then some debate about whether it's appropriate for a perinatal team to become involved. Unfortunately, from day-to-day clinical experience, I can relate that the frequency with which terminations necessarily go through is quite unpredictable. In this case, there was a lot of social factors that affected this woman's ability to access the termination, and some of these services, depending on how they're commissioned, can be some distance to travel to access, particularly depending on the gestation of the pregnancy as well. But in other cases, during the process of going through the counselling prior to accessing the termination, women may genuinely change their mind about what they wish to do with the pregnancy. And unfortunately, I think by delaying an initial perinatal mental health assessment, we delay timely access to care, which would be why I would necessarily advocate thinking about offering an assessment sooner, even if that then leads to signposting onto other services if the termination goes ahead, or if in other circumstances there's a miscarriage, for example. Next slide, please. This and other cases has led us to reflect a bit on some of the challenges about whether women are offered or considered for specialist perinatal mental health care. Sometimes there are questions about the continuation of the pregnancy, as I've just discussed. Sometimes there are questions about the likely outcome of the pregnancy in terms of parenting assessments and social care. Will the baby remain in the woman's care, for example? That can be the case, particularly where there have been a number of previous child removals. What I think is important is to acknowledge that perinatal mental health teams have a particular expertise in understanding, for example, the risks that arise at this particular time in life, understanding how mental disorders and presentations change in relation to the pregnancy and childbirth, and also just day-to-day working relationships with maternity services, health visiting, and social care. And so one of the recommendations that we've put in the new report, which has been a little controversial, I think it's probably fair to say, is just acknowledging and encouraging commissioners to facilitate perinatal teams to exercise a leadership role, even if they're not necessarily providing direct care for that individual. And that may be as simple as, when handing over to a general adult CMHT, just making them aware of particular risk factors to be mindful of, or times that may carry particular risks. So thinking about the point at which a family court make a final determination about whether a child is returning to care or not, for example, being associated with increased risk. In other cases, there may be need to have more of a scaffolding role in terms of supporting those other services, just to ensure that the risks are well understood. Next slide, please. This vignette, again, a woman in her 30s who had a diagnosis of emotionally unstable personality disorder, also previous label of bipolar disorder, history of multiple suicide attempts, a number of physical health comorbidities, and a known history of domestic abuse. And she'd been referred into the perinatal mental health team in early pregnancy, but was deemed not to meet their criteria, presumably, I would guess, due to the personality disorder diagnosis. She presented to the emergency department in the second trimester in distress after a fight with her partner, but left because there was a long wait. There was no further referral to the perinatal team, or indeed an appropriate safeguarding referral in relation to her domestic abuse. She separated from her partner 3 months later in the third trimester, and after she gave birth, there was no discharge plan and did not appear to be any plans in place for her safeguarding or mental health support, and she died by suicide 8 months postnatally after expressing both intent and a prior attempt. Now, this case, I think, illustrates one of the challenges around how some perinatal teams interpret criteria for their services. We do, when we're reviewing cases, come across scenarios where some teams talk about it not being a perinatal specific mental health problem, or that personality disorder is not necessarily appropriate for perinatal teams. Both of these views, I think, in my personal opinion, are not appropriate. Perinatal teams are a specialism that focuses on a time of life, not a particular disorder, in the way that, for example, EIP teams or ADHD services would do. And as I mentioned before, they really carry a particular expertise. If we think about diagnoses like emotionally unstable personality disorder, this is a condition that we recognize is often caused by early life trauma, abuse, difficulties in parenting relationships. And so by virtue of that, becoming a parent, transitioning into that parental role can often be associated with a lot of difficult memories and emotional disturbance that can lead mental state to deteriorate. So this is something we can anticipate. Next slide, please. For that reason, in the same way that we anticipate deterioration of psychotic and bipolar illnesses, I think it's important that we recognise some of these other conditions can also have a predictable risk of relapse and can benefit from input from perinatal teams. Beginning that therapeutic work and establishing a therapeutic relationship with somebody who may find it hard to build trusting relationships is a lot easier when things are stable antenatally than waiting until we're in a crisis postpartum. Next slide, please. Just moving on to think about loss. So loss of a child through any means, that can be antenatally, neonatal death, post-pregnancy, or removal through local authority proceedings, are quite commonly associated with both suicide and substance misuse. And these rates really are broadly very similar across the past few decades. So around 40% of women dying through suicide will have had some sort of loss event, and around 60% of those with substance misuse. And of course, in that group, often that's through family court proceedings by and large. So again, this is something we just need to bear in mind when we're undertaking our risk assessments and weigh that into how we're making our judgments. Next slide, please. Some of the challenges that we come across in relation to women who've died and access to perinatal services relate to lack of referral, and we're still seeing cases where women are not being appropriately referred through to specialist perinatal teams who've got an established history or where there's sufficient concern about their current mental health. Too restrictive criteria, so that would be, for example, exclusion of women who've got conditions such as personality disorders. Response times really not taking into account the perinatal context. And I know very much from my own day-to-day experience that pressure that we have on us trying to get women seen and taken into care when we've got the impending due date to work towards. And pathways and specialist care really complicating things. So it's been a wonderful improvement to have access to specialist midwives, for example, able to provide a really effective liaison function between perinatal mental health teams and maternity services, but they're not a replacement for those services. And sadly, we do come across some cases of women with diagnoses like bipolar disorder who are just solely being held by a specialist midwife and or specialist obstetrician, and that really isn't an appropriate way to manage the care. Next slide, please. I think we'll jump onto the next slide as well because I've covered most of those points. We've seen over the years a number of cases where there's been a failure really to engage effectively with relatives, and this can occur in a variety of ways. So one of them is not listening to information that relatives are trying to share in terms of their concerns, particularly about risk or deteriorating presentation. But equally also a failure to educate relatives about the seriousness of illness. And this is something that does happen, particularly with puerperal psychosis, where women may have no prior history of mental health problems. Often, a number of these cases, there's a trend towards women coming from relatively professional backgrounds, stable circumstances, long-standing stable relationships. Excuse me. And partners faced with a wife or partner who's seriously ill for the first time in life can find it very hard to contemplate just how unpredictably they can behave when seriously ill, and indeed the likelihood of serious self-harm, either self-harm or harm to their baby. And so we really need to very clearly but sensitively explain those risks when we're trying to balance up the appropriateness of community care versus inpatient care. Sometimes, and not infrequently, we come across cases of home-based treatment with crisis teams where partners are being asked really to manage totally inappropriate levels of risk. And again, thinking about those cases of psychosis where a partner is on their own trying to care for their the mother and the baby. If the mother in that case, for example, suddenly impulsively decides to leave the house, what are we then asking that partner to do, who are they going to stay with in that situation? It's potentially very unsafe. Next slide, please. This illustrates that I think the challenge of engagement with relatives. A woman who died by overdose several months after the termination of a pregnancy had developed a range of physical health concerns and received a number of investigations, but the possibility of an underlying mental health cause did not appear to have been considered. Her family became increasingly concerned about her mental state and contacted the GP repeatedly, describing a range of depressive symptoms and social withdrawal consequent to her physical health, which prevented her from going out. She'd indicated to the GP that she did not want information about her health disclosed to her family, and for that reason the GP would not see the relatives. Accounts were given to the practice of her engaging in self-harm, and the family attempted to communicate their fear that she might end her life. They'd contacted a mental health professional who also alerted the GP to their concerns, but she died on the same day. Now, hopefully many people are aware that confidentiality does not prevent us from receiving information from relatives. And indeed, it can often be really helpful to get that collateral feedback. We don't necessarily have to give them information about the patient's care, but there is nothing stopping us from listening to their concerns. Next slide, please. Again, a pattern over a number of years is consideration of protective factors, and particularly comments that are made not infrequently that children are a protective factor guarding against self-harm. So in this vignette, a woman died by violent means early in pregnancy and had a complex history of adversity, self-harm, and at times had attempted to end her life. On discovering her pregnancy, she'd recently taken an overdose and described ongoing suicidal thoughts, but when seen by a liaison psychiatry team, they documented her family as being strongly protective. Shortly before her death, she took 2 further recent overdoses, expressed thoughts of violent self-harm, and was drinking more alcohol. An urgently requested mental health assessment again cited her children as protective factors, and she sadly died 4 weeks later. So hopefully this brief vignette really illustrates and clearly hammers home the point that in this case, this woman had a long-standing history of self-harm. There were repeated acts of self-harm, and her existing children were not preventing her from acting in that way. And yet the risk assessments consistently said that they were a protective factor, and that was what was relied on in terms of next step decisions about her management. Next slide, please. Just finally, a couple of thoughts about other aspects. I've mentioned suicide misuse is also a significant factor in maternal deaths. Often what we see is a pattern around polysubstance misuse, combinations of opiates and benzos, also quite a number of cases where we've seen more recently cocaine and alcohol as well. A number of women who've died had been prescribed pregabalin or gabapentin. And in some of those cases, there was a case I reviewed a number of years ago where the GP clearly documented that the woman was asking for far too many prescriptions. So they were being collected sort of every 3 weeks or so instead of 4 weekly. And documented in the notes that this was not going to be permitted to continue. And yet they did continue to supply those prescriptions above and beyond what they should have been, and didn't have any discussions about referral to or make a referral to addiction services in that case. I think one of my other sort of concerns just from day-to-day clinical practice is the cases where we have pregabalin being prescribed for example, anxiety or chronic pain, and there's not really a recognition of the underlying mental health components to those presentations. So I think it can sometimes be, obviously not in all cases, but certainly with patients that are being referred through to secondary mental health services, can be a bit of a pointer to help us think about what else is underlying this. Particularly where there may be suggestions of a trauma history that we want to explore a bit more to help us understand the formulation. Next slide, please. This was a a vignette which we published a couple of years ago, just thinking about one of the substance misuse deaths. It illustrates a number of points. A woman in her 30s who died by violent suicide 7 months postpartum, had a history of alcohol dependence, to the extent that she developed Wernicke's encephalopathy, so a really serious consequence of chronic alcohol use, and also experienced delirium tremens as well, so withdrawal. There was a history of recurrent overdose. Shortly before her pregnancy, she'd engaged with addiction services and had been commenced on alcohol treatment with acamprosate. However, she then defaulted from follow-up. She was reassessed by addiction services mid-pregnancy, who noted she'd been abstinent from alcohol for most of the pregnancy, but also noted a number of depressive symptoms. She was discharged back to the GP, presumably because she wasn't drinking, but did not attend an arranged follow-up appointment. After giving birth, she developed worsening depressive symptoms, later complicated by a return to alcohol misuse. So this is a really complicated scenario, but Wernicke's encephalopathy is often associated with cognitive difficulties, memory, for example. So one would immediately be wondering about this individual's ability to really remember about appointments and get herself to appointments, not least if she's then also returning to alcohol use. And she really needed a much more assertive input from services to try and help engage her and assertively get her into follow-up. Next slide, please. I've talked, I guess, a fair few times through this presentation about the number of cases where we see patterns of trauma and adversity underlying the difficulties that we're dealing with. And I was struck when asked to be involved with one of the other chapters for Embrace a couple of years ago, that are very similar patterns in a number of other situations, both with women dying through accidental means, but also through homicide as well. When we look at accidental deaths in the report for 21 to 23, there were 15 women that died through accidental means. These often may include things like road traffic accidents, for example. Many of them also had this pattern of a multiple adversity and early life trauma. One of the cases that we look back at in 2020 saw a woman who had a marked increase in risk-taking associated with alcohol and amphetamine use. Her baby had sadly died, but this information had not been passed on to the mental health team, so they weren't able to take that into account when they were thinking about her engagement or disengagement. She'd not been referred to addiction services despite this ongoing use of substances. And in the context of the alcohol, drugs, and risk-taking behaviour, was a passenger in a car and sadly died in a road traffic accident. And it really illustrates the importance of thinking about these patterns and trying to anticipate how the different factors may be influencing each other. Clearly, in that scenario, this is not something that a team is going to be able to go in and resolve themselves, for example, a perinatal mental health team. But we need to be working together in a multi-agency fashion to try and get women the help that they need. Next slide. So again, within the 3 years, 21 to 23, there were 14 women who died through homicide. Virtually all of these died at the hands of their partner or former partner. Of those 14 women, 6 were known to be victims of domestic abuse, but there was also missing information about whether they'd been known to have domestic abuse in at least 2 of those cases. And this rate is relatively standard again over the years. So often histories of domestic abuse are not well identified. And I think it's, as with substance misuse, it's an area which we just really need to be very mindful of and to be asking the question frequently and not just doing it as a one-off, say, at a midwifery booking appointment. Next slide, please. Again, in all of these cases, as you might imagine, multiple adversity was a common theme. A number of them that we've seen have issues with mental health, substance misuse, or other vulnerable status, so being asylum seeker, for example, or non-English speaking. Next slide, please. So overall, complex adversity, particularly childhood adversity, is really common in all these forms of death. So women dying through mental health conditions, through suicide, substance misuse, accidental deaths, and homicide. We see patterns of involvement with social services and addiction services and domestic abuse services. And of course, the challenge here is that often they may less well engage with both maternity services and mental health care. So that really gives us a challenge about how can we work with these women to reduce their risk. It may be that in some of these cases we have to be quite inventive about how we engage them and be careful not to overwhelm them with excessive numbers of appointments. There was a fantastic study published earlier this year based on Embrace data by Kat Becker that looked at just the number of appointments that some of these women are asked to attend, which just really is completely overwhelming. It'd be overwhelming for any of us, really, but for somebody who has had a difficult background, who perhaps has difficulties in planning and organising themselves, who maybe have some financial challenges and struggle with transport to get themselves to appointment, and also just be very afraid of what professionals are likely to do. Is there going to be a question about removing their baby? That it's just such a huge thing to ask them to try and get to all of those appointments. So there needs to be a focus, I would argue, in those cases about what are the key things we want them to get to. We want them to get to their antenatal maternity appointments, of course. If substance misuse is a primary factor, maybe we focus on engaging them in that, and then using those contacts as a proxy for judging how their mental health is. And only once those things start to improve, then gradually trying to work with them around the mental health aspect of their care, for example. But again, it brings us back to this multi-agency question. We need to develop structures to help us to work effectively as a multi-agency system. And that's really challenging with the resources that we all have at the moment, finding that time to have those meetings, effective communicating across different organisations. Next slide. So I think this is a final vignette. A woman in her 20s died of an overdose. She had a history of mental health difficulties, including anxiety, low mood, self-harm, alcohol and substance misuse, including prescribed opioids. She was in an abusive relationship and her lifestyle was described as chaotic. She was also being investigated for headaches and seizures. An older child had been removed into family care, and there were ongoing child protection proceedings in the current pregnancy, which ultimately resulted in her baby going to foster care after birth. In the months after delivery, she became homeless. She was also involved with a number of agencies, perinatal mental health team, addictions, crisis, social care, neurology, and the focus of all of these agencies seems to have been on symptomatic management of their specific conditions. And while different services did communicate with each other, there was limited true interdisciplinary working or an attempt to understand the reasons behind her difficulties. Assessments were quite superficial in nature, and on one occasion, a crisis team's assessment tool recorded no risk identified, despite a very recent overdose and arguably a really complicated history, which is fraught with risk. So a case really where people needed to come together and think about what is driving this woman's difficulties, what is underlying the challenges, but around substance abuse and mental health, the physical symptoms, the headaches and seizures, are these, truly totally independent, or are these manifestations of the underlying difficulties that we need to understand? Next slide, please. That concludes my presentation. I'm very happy to answer questions now.
Thank you, Dr. Gaines. What a fantastic and insightful presentation, and some really interesting things there, from the importance of those transfer from perinatal into generic services. And I think one of the things that resonated with me that comes across all the themes is about that listening to experts by experience, listening to relatives and carers. There was a theme of that through, and I think that's a really important issue. But I could go on for a long time, because obviously it's some really good things there, and some really sad some very sad cases, but I think we need that to be able to get the discussion going. We've had some great questions that come in, so shall I start on those and then I can maybe add some of mine later if we get time.
Yeah.
So we've had a couple from Claire Marshall. So the first one is about that vulnerability. So based on what you've mentioned about vulnerability and the risks to women who are separated from their infants due to child protection concerns, etc. What do you envisage the best practice role for specialist perinatal mental health teams, and how do you feel we can reasonably provide it?
Yeah, it's a really good question. So I think my personal view on this has changed a lot. So when I began training in perinatal psychiatry in Nottingham, the general perceived wisdom at that time was that if a woman was to have her baby removed from a care, it wasn't appropriate for her to remain with perinatal services. And the rationale for this was really that it would be distressing to her, for example, to be coming into waiting areas where other women were there with their babies. I think what has become apparent to me is that unfortunately not providing care under specialist perinatal teams mean that generally these women just don't get any care at all. General adult services often don't see the need for them to receive mental health care, or they don't understand the risks, particularly around these important times, baby being placed in foster care, formal decisions by the court of permanent removal. And often they will take a much less cautious approach to discharge. So, one or two missed appointments, even when there's a lot of risk, they will still just discharge outright at that point. And I think the expertise that perinatal teams have, the knowledge of working with other agencies and those established relationships can be really very valuable to ensuring that these women get the care that they need. So I've come to the view that we should be providing that, but I would acknowledge that that's not yet a widely accepted view across the country.
Okay, thank you. That's interesting to know. Might come back on that later. We've got lots of questions coming in, and also from Claire. Obviously, I've already mentioned that there's been quite a lot. You mentioned a few of the cases which are tragic, with negative outcomes, which I think we need to have a conversation. But have you got one thing you could share with us about the positive impact that perinatal mental health teams have made in the last year?
So the case that we've presented a number of times in Newcastle was one of these very complicated cases that really fantastically benefited from perinatal services input. So we worked with a woman who'd had a previous history of child removal. She had difficulties with substances, particularly alcohol, prior mental health problems and self-harm, and came into our care, worked with CPN care coordinator and did work with our nursery nurses. Fortunately, children's services, because by that point she was abstinent from substances, allowed her the opportunity to care for the baby postpartum and undertake their parenting assessments with the child in care. And given the work that she was able to do with our staff, really managed to embed the stability that she'd got with the child in her care and had a really positive outcome. In the end, the child protection plan was stepped down to child in need and then closed, and she now remains with her daughter in her care. And that, I think, would have been much harder if she'd not had that support. For her, the challenge, of course, of having this baby with the previous child removal, she found really quite triggering, because of the guilt, I suppose, for what she felt that she'd lost in the past. But this was a really positive outcome.
Perfect, thank you. Great to hear. One of the things that I think we're all, because obviously we're here as a collective, as a collaborative, we're doing it on behalf of the system, as it were. And I just wondered what things, and Debbie's also mentioned this as well, Debbie Wilson, about what are the key things we can do as a system, as partners, to connect with the specialist perinatal mental health services. What are the key relationships? Because I mentioned that, because you mentioned in your talk about that handover and transfer. There are a couple of key things that we should be working on, and maybe can take those away with us.
I think there's a key thing for commissioners here to help commission services that have the time and the capacity to support other services and agencies. So it isn't just about providing the direct one-to-one, face-to-face contacts and care for patients. There's also a huge amount of work that perinatal teams have historically done, I think increasingly struggle due to the demand for services, which is about providing advice to community teams, perhaps around preconception care, advice to those services, picking up scaffolding of other services. I'm minded of a woman who, in fact, I never met, but provided scaffolding to adult safeguarding services, maternity, around the management of her care and risk. And we work really effectively together in that way. But superficially, because I'd never met her, she wasn't really receiving a service from us, but we were still able to try and think about how we kept her safe as best we could. So there's something about ensuring that that's commissioned as part of the services. The other aspect of it, I think, is having established meetings. So making sure we've got those regular check-in points with other services, particularly thinking about talking therapies, for example, addiction services, social care. So making sure that we're picking up cases that are coming through and that they're not getting missed and they get triaged into the right care at the right time.
Thank you, really helpful, and I'll come back at that as well. But let's go through some more questions. We had one that's got a lot of likes as well from Katie Morley, which is around wondering that obviously some perinatal mental health teams are moving to 24 months postpartum. Will the next Embrace report reflect that time period?
Probably not, is a short answer to that. So with it being a statutory report, the time frame is set by the government when they commission it. And also, I guess it's all, we've got to think about how the data compares internationally as well. And that's one of the reasons why the data is broken into the antenatal to 6 weeks and then the late deaths separately. There would also be challenges around ascertainment, although that wouldn't be entirely insurmountable. But no, I think it's not likely to change in that way.
Okay, it's maybe something that we need to think about helping you with as well, especially with services moving. So, from Lynette Robinson, who asks, what is your view on the lack of dual diagnosis, substance misuse, mental health specialism?
Heavens. Well, I mean, I think there's general acceptance that the old approach of saying that people need to go away and sort out their substance misuse before their mental health gets treated is no longer acceptable or evidence-based. There's a real challenge, however, I think, in terms of providing that care. And one of the problems we've got, I suppose, to come back to commissioning, is the way in which our addiction services are increasingly commissioned. Third sector services really have a value in terms of providing addiction services, but I think the loss particularly of psychiatry out of addiction services has been quite a significant downside. In terms of dual diagnosis services, I think from a perinatal point of view, you would still have the challenge really that those clinicians wouldn't necessarily have a perinatal specific focus. But I think it is important that we do not exclude simply by virtue of substance misuse women from accessing mental health services.
Yeah, I think it's back to that linkage, isn't it, and that relationship, that both from a partnership point of view, but a relationship between the services, doesn't it? Because they're not mutually exclusive. So I think the more we can do that to support practitioners, the better. So I think it's a really interesting point, and maybe the whole thing of another conference itself, really, to be fair. But thank you for that. Got one from Robert. It's about, obviously, thanks very much for sharing your experience, and obviously, which has been fantastic. But it goes on to say that your remarks regarding safety planning and the documentation of children as protected was intrigued him, and obviously something what it was relating to was something that he's come across working in perinatal CMHT. So it's asking about what you would recommend in this regard. Would you advise this never to occur or only under certain circumstances?
So I
Some
think
great questions this morning, everybody.
yeah. I think the problem we're getting at fundamentally is the question is more, why do people write these things down? Even though the facts essentially are saying to them that this is not a protective factor, why are they still documenting that? My suspicion, And of course, you can't prove this without going back and talking to the individuals, the clinicians who did the assessment, which we are unable to do given the methodology. My suspicion is that because of the pressure that many clinicians are under, the demands that they're under, and the need to try and limit the volume of patients that we're getting coming through, crisis teams are under tremendous pressure. I know in our area, the waiting time for assessments is really substantial, that people need to try and filter patients out. And so I suspect that probably unconsciously, people are trying to hang on to things that they can use to justify why somebody doesn't need ongoing crisis care is fundamentally what we're getting at. So what I think we need to be doing is trying to be honest about the challenges that we face. We need to document risk accurately, and if we genuinely feel there are no protective factors, then that's what we need to be acknowledging. The challenge is then how we develop a plan out of that, and how we manage that within the resources that we have, which is not an easy balance.
Yeah, thank you. So going on to Lorraine's question from York and Scarborough around women suffering loss, who don't have their baby with them. She's asking, how can we support and reduce the risk for this group of women where crisis often dismiss them? And it's when crisis often dismiss them, even when they appear to be a significant risk, yet they really struggle or can't access perinatal mental health input.
So that relates really back to recommendations that we've made a number of times over the years, which is about the need for crisis liaison and other access services to be having regular updates on perinatal mental health, and acknowledging that this is a particular risk time, and that in those situations they may warrant that input from a crisis team, even though normally at other points in life that wouldn't have been felt to be necessary. It's recognizing that dynamic factor, I think, isn't it, of this is an additional stressor at this particular time that is not to be dismissed.
Yeah, and maybe that's something we can help work with in the collaborative about supporting more generic services with that. So maybe that's again something, another point to take away. Thank you for that, very helpful. Sophie mentioned a really good point that I was going to raise, because we do work with different multi-sector. As I said earlier on, we've got local authority, private sector, voluntary sector in the audience, and it was around the VCSE about them getting increasing referrals with pregnant women and new mothers experience of trauma. And they're not under secondary mental health services. So the question from Sophie was, how in the community sector can we upskill them to meet the needs? Because if they can't refer into the specialist services, and some women are reticent to do that, how can we help support the VCS sector in those cases?
I mean, I suppose that would link back to what I was saying about perinatal teams having the capacity to support other teams, either with advice or training fundamentally. It's going to depend necessarily on the existing sort of setup of services, what there is in a particular area. For example, in Newcastle, we have the fortunate, we've got a parent-infant partnership arrangement set up. So there's that expertise that can be drawn on, I suppose, to support some of these women alongside VCSE colleagues as well. But it's about trying to ensure that we can support them with advice and training. I think it's the crucial thing. I mean, I would add that VCSE colleagues can be absolutely amazing at engaging some of these mums. As a doctor, I know to my cost that I think patients sometimes find it quite tricky to come and be open with us and talk about some of the difficult stuff that they find much easier to talk with. For example, nursery nurses in our team are wonderful at eliciting histories, because patients just feel so much more at ease than they do perhaps with a formal doctor consultation on occasion. And VCSE colleagues are often in a very similar situation. They're much more trusted, and families find it much easier to be open and honest with.
I couldn't agree or disagree with that, but I do take the point about that, and I think it makes perfect sense. Dr. Cairns. And moving on, we've got a few more questions. See if we get a few. Certainly, this has got a bit more time to get some in. So great questions, by the way. Thank you so much for submitting them. So Helen McConnell was saying, do you work with MNVPs to further develop and decide the focus for perinatal mental health moving forward?
Regions in North East North Cumbria, that was something that we'd done in the past. It hasn't been more recently, so we've been setting up our own lived experience groups specifically for perinatal mental health. One of the challenges we found was that the representation in those groups didn't sufficiently cover mental health for secondary care. That was one of the difficulties. But certainly MMVPs have, been a wonderful resource across maternity. I think it's well recognised.
Okay, thank you. And again, another one of my questions, I can just sort of tick it off my list because it was something that was really important. Because I mentioned right at the beginning, we'll pick up a little bit later around the changing and developing NHS landscape. Steve mentions about that changing landscape. So what his question is, how would you envisage perinatal specialist teams embedding effectively within these new neighbourhood mental health, well, just neighbourhoods, but also there's going to have some bits of mental health within them, and how can we develop those to fit in and to work with the women and families in that perinatal mental health sphere?
This has always been a challenge, I think, really. So by virtue of the numbers of referrals that perinatal teams get, and the expertise, we've tended to run teams over across relatively large geographical patches. So, for example, my own community team that half of my job relates to covers all of Northumberland Town. So a vast geographical area, and it makes sense from a financial effectiveness point of view to commission a team across that sort of patch, because we can spread the expertise and the staffing resource across all of that. But yes, on a local level, you've then got to maintain those relationships, be that with a place-based commissioner or with a family hub or with your local maternity unit. So we have 6 or what have you. And I think the answer to that is not necessarily suggesting that we need really small teams, but identifying individuals within the team that have those working relationships with that patch. So, for example, for our CPNs, we have CPNs that work in particular localities, so they can maintain those local relationships. Previously, we've also had CPNs going into maternity units, into the mental health clinics, to maintain those one-to-one relationships. But you have to work at it. It's certainly not easy.
Thank you. We've run out of time, but the questions, there's a few more questions which we'll try and get answered outside and get back. But I'm going to end with a quote somebody from Vixen Brown, who said, Dr. Cairns, I'm pleased that you mentioned the restrictive referral criteria for perinatal mental health teams. Have referrals declined by the perinatal mental health teams due to pre-existing mental health diagnosis, substance misuse? So that was just a comment, just saying thank you for mentioning it. So I suppose my one final thing was, if you could obviously summate all the things that we've chatted about this morning up to now, which has been huge amount of information. It's been fantastic, and I'm glad we're recording it because we can listen back on it. What would be the one thing that you would expect us to take, or would like us to take away?
So I think the key thing is that we really need to develop multi-agency systems to work effectively to support the care of these women, because so many of the women that are dying, through whatever means they die, have complex histories. We cannot expect any one service to be addressing their need. We can't expect our perinatal teams to resolve all of their issues. We can't expect social care to come in and resolve all of the issues. We have to be doing this together. So we need the structures and the relationships to be able to work together across that whole network, to make sure that women get the care that they need and families get the best start.
And that's great for us to take away. Thank you for that. And obviously we'll build on some of the things that you mentioned about that regular check-ins, the picking up cases, the BCSEs piece and the risk, etc., and that transfer. So lots of things for us to do as a collaborative that we can work through. But thank you so much. That time's just absolutely flown by, and it's been really, really informative and really a great way to start the conference and the Monday morning for me. So thank you so much for your time, and
Thank you,
we've got a couple
Evan.
of outstanding questions which we'll get you to answer and send the answers in. But thank you for your questions as well. But thank you, Dr. Cairns. Great session. Thank you.
Bye, everybody.
Okay, thank you. So moving on next to our showcase, our local showcase. I think Dr. Hayes has really set the scene and given us lots of information there and lots of things that we need to take away. But we're also doing quite a lot as well. So let's have a look at that and just see where those gaps are. So we've got a couple of things to do at the moment. The first one is Claire Marshall, Specialist Perinatal Mental Health Nurse, Clinical Lead, Specialist Perinatal Mental Health Team at Humber. That's a bit of a mouthful. He's going to talk a bit about the circle of security of parenting. And then we're going to go on. I'll do this seamlessly because I'll let them just follow on from each other. There is a question and answer session later. But then we're going to have Emma, and I'm hoping I pronounced his name right, Casta, apologies Emma if I've spelled that, got your name wrong, who's going to do specialist parent and infant relationship nurse, working with Marion Quinn, consultant clinical psychologist and clinical leads at Navigo. They're going to do a bit about growing well, and they're really great. And then we're going to have a couple of videos as well. And again, keep the questions coming because we'll have some questions and answer sessions after that. So over to Claire and Emma and Marion for the next fantastic session. So good morning, everybody, and welcome. And I really look forward to this. Thank you.
Good morning, everybody. I hope you can hear me. My name's Claire. I've been introduced, and I'm here today from the Specialist Perinatal Mental Health Team at Humber. And I'm going to be talking to you about infant mental health and the implementation of the Circle of Security intervention into a specialist perinatal mental health team. And I'm also going to, hopefully it's all right, talk a little bit about the Humber Perinatal Mental Health Team and why infant mental health is important to us and why infant mental health interventions are needed by specialist perinatal mental health teams. Next slide, please. So a bit about our regional specialist perinatal mental health team. Specialist perinatal mental health teams, if you don't already know, a lot of you probably will, but we provide specialist psychiatric and psychological assessments and care for women and their babies with moderate to severe or complex mental health problems during the woman's pregnancy or up to the first postnatal year. Now, nationally, some teams will support and treat women up to the second postnatal year, but in our region, we're not able to do that due to funding issues. We also provide preconception advice for women with complex or severe mental health problems, and that's whether their problems are current or previous. Next slide. So a little bit about the history of our team, because we haven't been here forever. We started in 2010, just covering the Hull area. I started with the team in 2010, along with my lovely colleague, Katie Morley, who's currently our service development manager. We were a tiny service, but we expanded into the East Riding in 2014. Then in 2018, we had further expansion across the north and northeast of Lincolnshire. So we really snowballed. Humber Teaching NHS Foundation Trust is our lead provider, working in partnership with Navigo to cover that quite large geographical patch. Dr. Cairns referred to it earlier, that perinatal teams, we are a specialist service, so we tend to cover quite large geographical areas. And we work closely with the maternity services, covering 2 acute trusts. Thinking about our birth rates then, so how many women might we get involved with? The birth rate across our region for the Humber Trust's perinatal team, there's around 10,000 births per year, 6,000 generally just in the Hull area. So Hull is the biggest area for births. And generally, we see 8.6% of the birthing population. If you think that around 1 in 4 women might have some level of mental health problem or emotional problem in the perinatal period, so that's 20%. We see with the 8.6% with the most severe problems. Next slide, please. So I think we're really privileged in our area. We've got an amazing team. This slide is slightly old because I've said we moved from about 3.2 members of staff back in 2010 when I first started. There's now about 55 of us covering that patch. And we're initially just a couple of nurses blundering through and a psychiatrist, feeling our way. But now we have consultant perinatal psychiatrists, we have early years practitioners or nursery nurses as they're sometimes called. We have family therapists, peer support workers, specialist nurses, occupational therapy, CBT, and of course we wouldn't function at all without our amazing admin team. So a really large team, and fortunately able to provide a real range of interventions to the women that need our help, the women and families that need our help. Next slide, please. So thinking about the kind of problems that the women we see have, which is some kind of mental distress or mental illness in pregnancy or after the baby's arrived, what we know is that that has a significant impact on how the woman might feel about her parenting ability, how she might feel about herself as a mother, and how she might look after the infant. And this really is the issue where perinatal teams have to focus on infant mental health or infant attachment relationships, because it's this early relationship that impacts on an infant and a child's future. So infant mental health describes a young child's capacity to experience, regulate and express emotions, form close and secure relationships, and explore the environment and learn. And all of these things take place within a caregiving environment that includes the family, the community, and cultural expectations for young children. Now, across the world, across the whole world, globally, families look differently, communities look different, the way we live in our homes or not homes might be different. But what is key from the literature and evidence is that child development and positive child development and growth does require secure, stable, safe relationships from a very early start in life. And essentially, this is all about love and relationships, and we see this globally. Next slide. You may have heard of the 1001 critical days, and the 1001 days describes from the baby's conception to their second birthday, so right through the pregnancy until the infant is 2 years old. And during this time, the baby's brain develops faster than any other stage in their life. And it's these developments that provide the foundations for the lifelong well-being. So it's critical that we're able to identify any problems that might occur in relationships, the baby's safety or sense of safety. And babies rely on their parents to meet their needs, and responsive, sensitive care strongly supports early development, early brain development. Next slide, please. So that there are some key factors that might impact on parental or infant relationships, or problems with attachment, or problems with the difficulties in infant mental health, if you like. And I'll just quickly run through them. At the top there is parental factors or vulnerabilities, and those issues are key for specialist perinatal mental health teams, because I guess for our teams, working with women who may be experiencing mental illness or distress, and often that can lead with great doubts to their parenting abilities. Dr. Cairns referenced it in his previous talk, and that can often lead to the mother having doubts about her interactions, not feeling confident. Issues such as drug and alcohol misuse, those kind of things can impact on parent-infant relationships. There can be infant factors, For example, not all infants and babies are the same, are they? Different babies have different temperaments, different likes and dislikes. Some babies seem to go to sleep easier than others. Some babies seem to feed easier than others. And for a range of reasons, of which some we don't know. You may think about your own children and the differences in your own children, but you're not sure why those differences are there. But those would be described as the infant factors that can get in the way, perhaps, of positive parental or infant relationships. The family and social environment is key. Women and families in mothering do better when you've got a stable structure, or scaffolding was the word used earlier, scaffolding around you to have a positive and stable family and social life. But what we know is that many of the families we work with are living in difficult social situations, poor housing, don't have any money, might not have access to public funds, there might be domestic violence. So those are the kind of things that get in the way of parent-infant relationships. Physical health and development, and that's linking in with early life experiences as well. So, for example, there are many things you could mention, but for example, a baby that's born with a health condition or born prematurely and maybe separated from mum at birth, and early life experiences that might make it be a challenge really to those early days of life. And these experiences can occur before the baby's born. For example, when the baby's still in the womb. There's some literature on domestic violence and outcomes for infants when they're born, when the domestic violence has occurred in pregnancy. So just to give you a bit of an idea of what we're talking about when we talk about infant mental health and the kind of things that can get in the way of that and in the way of parent-infant relationships. Next slide, please. So the Circle of Security is an intervention that aims to try and help with these difficulties. We shorten it to COSP or COSP. So if you hear me mentioning COSP, this is what I'm talking about. The Circle of Security is a relationship-based early intervention programme that helps caregivers understand and respond to their child's emotional needs. There's some American terminology throughout this because it was developed in America. It's built around the idea that children feel safe to explore the world when they have a secure attachment to their caregiver. Next slide, please. And in our specialist perinatal mental health team, in identifying over recent years, the importance of infant mental health and relationships has become much clearer to us. So over recent years, our team has focused on what we can do to help in this area. Nationally, this has been a programme of work nationally as well, and with local authorities through the Best Start to Life funding that you may have heard about. Our team offer a range of assessments. Our staff are trained in a range of assessments. So tools or skills or scores that can help in discussion with the mother and family, identify any attachments or relationship issues. We might use the PIOS, which is the Parent-Infant Interaction Observation Scale, the Me and My Baby tool, newborn observations. And then we have a range of interventions, such as Watch, Wait, Wonder, infant massage, video interactive guidance. The Circle of Security is the intervention we're going to talk about in a minute, and also Grow Brain. There are others. What's important though in working with families is that there are certain interventions, just like any intervention, medication, therapy, certain types of medication, some women and families won't want one intervention but would want another. There may be things about them that they don't like and couldn't tolerate. For example, video interactive guidance involves the mother and infant being videoed and then reflected on with a trained clinician. Some women wouldn't be able to tolerate that. They might find it too frightening or too difficult or too intrusive. The Circle of Security is a group intervention. So again, some women, don't feel that they can access groups. Again, it's too frightening for them. So it's about trying to find out what intervention is going to suit that woman and family best. So we've got a toolkit, if you like, of interventions. Next slide, please. So I'm going to focus now on Circle of Security, or COSP. So COSP is a manualised intervention. I was trained in the intervention along with several of my colleagues. I think it was year before last. It's an American intervention that was developed by a group of infant psychotherapists. And we use a manual. So we're directed to what we should cover each session. And we use video footage. Well, the video element has been one of the big challenges because I always say I'm a clinician, not a technician. So trying to get videos to play as well as doing an intervention has been a big challenge, but we've got there. So we show videos of parents and mothers, dads, parents interacting with their infants. And we reflect on those videos in the room, sharing our own narratives, our own stories, using, I guess, attachment-based theories to look at what we thought, the things that were positive, what the child needed, what the parent was doing. And this intervention is meant to be delivered in 8 sessions, and each session is called a chapter. And it's meant to be delivered over 12 hours. What I know is that it takes much longer than that. I'd be interested to hear what there'll be other COSP facilitators on this conference today. I'm interested to know what other people think to that. I'd say it's probably more like 20 hours over 8 sessions. But that's probably, it might be because so our perinatal team deliver this intervention face to face and with the babies in the room. So you can imagine you might have 6, 7 women, their babies arriving. It can be noisy, mums need changing, babies need feedings, and we need to serve tea and toast. That's a critical part of our intervention, tea and toast, because the mums have often travelled across the city on the bus and they haven't had the breakfast. That was one of the things we learned early in our first cohort. But we need to make people feel comfortable and cared for in coming to the group. And this intervention helps parents understand the children's behaviour and emotional states through a more empathetic lens. We've got groups now running across our 4 patches. So at any given time, we're running a group in Holy Striding, North and North East Lincolnshire, which we're really proud of. It's taken a bit to get off the ground, but we're getting there now. Next slide, please. This is a bit of a complicated picture, but this is the circle of security. You can see the circle there, and on the left-hand side is a picture of hands. And the hands represents the mother or the parent or the caregiver who needs to be the secure base and the safe haven for the infant who is going to use this circle to explore the world. The infant needs the parent to support their exploration of the world, watch over them, delight in them, help them, enjoy with them, and then welcome them back to the safe haven after they've done that. So this is, in principle, the foundations of the circle of security. And as facilitators, it's important that we are providing a secure base and safe haven for the women in the group as well. So as facilitators, we'll share our own experiences of parenting as well. Next slide, please. So one of the key elements of the circle of security is almost everything you need to know about supporting security in 25 words or less. And that is, always be bigger, stronger, wiser and kind. Wherever possible, follow my child's need. And wherever necessary, take charge. I'm going to come on to that in a bit more detail in a minute. Next slide, please. And the key concepts of the circle of security intervention is totally underpinned by attachment theory and put in an easy to understand, practical manner that parents can understand. And I'll just quickly run through these key concepts. So safe hands, I've already explained. It refers to the parent's role to support exploration and provide comfort and protection when the child needs it. And when your child is curious, playful, or wants to try new things, watching them and enjoy things with them. But you don't have to be perfect. None of us are. When it goes wrong, as it will do, be kind, repair, and keep going. The next concept is being with. And this is one of the most powerful things a caregiver can do. Sharing the child's emotions, sometimes not being able to fix it and not trying to fix it, not distracting or dismissing the child's feelings, because all feelings are welcome, but some behaviours are not. For example, you might encourage a mum to say to their toddler, rather than get cross at them or lose their temper because they're doing something that's dangerous, or that they've got cross that they haven't got the lolly or something, you might say to them, "You're really upset right now, but I am here." Or if a child's got overexcited, "You're really excited, I see that." So acknowledging feelings and being with them. The next concept, BWSK, is bigger, wiser, stronger and kind. And I talk about this a lot, both in my own family life now. I'm a mother of 3 teenagers, and being bigger, wiser, stronger and kind has made me a better person. I also think it fits with our working environments, because the concept of, I'll talk through them. So to be bigger means you can handle feelings, and you're going to be the grown-up in the room. Being stronger means providing protection and boundaries. Being wiser doesn't mean being cleverer than anybody, but it means using your judgment to work out what your child needs. But thinking about the work setting, when dealing with colleagues, when challenging situations at work, wiser can mean using your judgment to work out what's needed. And finally, but most importantly, being kind. So you deliver all of these things with warmth, empathy and kindness. And then there's the shark music. We have a lovely little video where we show an animation with shark music, you know, the Jaws music. And this represents the uneasy feeling that parents might get when they sense danger, but they're not sure why, perhaps. Like in a film, some music plays, and you know that something bad's going to happen, but it isn't yet, and you're not sure. Helping parents establish what their personal shark music was and why and where it's come from, and often it's to do with their own childhood experiences themselves. And critically, rupture and repair. This refers to when there's a momentary break in the relationship with your child or infant. You might lose patience with them. You might shout at them, get cross. Or your child might withdraw and be angry with you. It's normal and expected at times, but it's about acknowledging it, taking some time and coming back and working out how to move forward. So those are the key concepts, and it's so simple, isn't it? But so wonderful. Next slide, please. So I'm coming towards the end now. I just wanted to provide you with some of the feedback from the mums that have attended our circle of security groups. This is from our whole cohort, from the last cohort who finished in September. I'll just read a couple. So one mum said, "This group has been amazing, both in terms of the content we've been taught and in terms of meeting other mums who understand and can share that things aren't always easy. I've looked forward to coming each week and I feel like we've made good friends." Mum 3 said, "I never expected a group to make me reassess my entire life and relationships and provide the tools to help me reassess and build better." And Mum 4 was a mum that wasn't sure whether she could come. She was very frightened about being in a group setting, recovering from a mental health problem, and she was just very scared. So she wrote this for us to share with maybe other women that are in the same position thinking about joining us. So she said, "Don't be scared to show up as you are. You are allowed to be yourself and bring all your mess as you learn that you are an amazing person as you are. This group has helped me to feel confident in myself as a mum and finally open up to other people." We just get such wonderful feedback. Throughout all of the sessions, the women sit together and share the challenges and their fears and support each other. Next slide, please. And that's the end of my talk. Thank you for listening.
Thank you so much, Claire. We'll go straight on now to the next presentation. That's okay, and welcome Emma and Marion. So good morning, Emma and Marion.
Good morning. I'll just wait for the slides to come up on the screen. So myself and Emma, so we work in the Navigo Parent and Infant Relationship Service, which is called Growing Well Together. So I'm going to start by talking about our experience of working with dads in the perinatal period. I'm going to talk a little bit about the research in terms of kind of sort of dad's mental health in this period, what they struggle with, and then Emma's going to talk us through some co-production work that we've been doing with dads, and also show a video of a dad talking about his mental health, his parent-infant relationship, and the support that he's received from our service and how it's impacted on that relationship. So if we can go to our first slide, please. So so I've already mentioned who we are. So our service is based in North East Lincolnshire. So we were funded through the Start for Life funding, and we are a parent-infant relationship service. So our primary focus is on supporting, sort of offering specialist support for families to help them to develop really strong, close relationships in terms of their bond with their baby. So we can work with any primary caregiver. So we're really, really privileged that we can also support dads in this process of adjusting to parenthood, and really support infant mental health and parent-infant relationships in the first 1001 critical days. So we can offer support from pregnancy right through until baby turns 2. We're a multidisciplinary team. I've put some information about who we are and some pictures. So we've got psychology, we've got specialist nursing, we've got early years practitioners, amazing admin, and an assistant psychologist as well. Okay, so next slide, please. So I'm just going to talk a little bit about what the literature and the research says about that, I guess, psychological adjustment to becoming a dad, because we do hear a lot about sort of there tends to be a lot of focus on mums and maternal mental health, which is obviously incredibly important, but I think paternal mental health has been overlooked in sort of both in the literature but also clinically as well. So what the literature tells us is that that men do experience are more at risk in that sort of perinatal period in terms of their mental health. So the rates that we've got are that's something between 5 and 15% of dads in that perinatal period are experiencing depression or anxiety. We also know that that the father's mental health has a massive impact on the well-being of the baby, and that baby's kind of outcomes. So similar to maternal mental health, what we're seeing is a similar picture in terms of the impact of having positive mental health on that sort of the baby's in their mental health, their well-being, and their development going forward. And we know how important that is within those first 1001 critical days. We also, an interesting finding in the literature is that there is a positive correlation between paternal mental health and maternal mental health in the perinatal period. So it's not always the case, but there is a higher risk of, if we are maybe seeing a mum in the perinatal period who's presenting with mental health difficulties, that partner is also more likely to also be presenting with some and experiencing some mental health difficulties themselves. What we also know is that good paternal mental health can really support sort of both the baby and the mother if perhaps the mother is experiencing some mental health difficulties. So next slide, please. There's not a lot of research in terms of kind of getting the views and that sort of story and experience from dads in terms of their lived experience of becoming a dad, kind of their well-being around that period. But this was a really good study by Darwin et al., which used invited partners, well, specifically male partners of mums in the Born and Bred in Yorkshire cohort study, and invited them to come and take part in a sort of in-depth interview to talk about their experiences. And this is some of the themes that came through that piece of research. So typical to research on men's mental health in general, what these dads were how they were describing their mental health was a little bit different to maybe how women described their mental health. So men were tending to kind of use the word stress in reference to their mental health, and sort of tending as well to kind of focus on more cognitive symptoms and physical symptoms of mental health difficulties. So talking about like feeling tired, exhausted, poor motivation, poor concentration, irritability, and also guilt as well. So there was a lot of descriptions around sort of feeling guilty about even sort of discussing that and highlighting that and talking about themselves. They were more likely to talk about sort of kind of struggling in terms of their well-being postnatally, so rather than antenatally. And I guess it's worth saying that all these dads were first-time dads and they were living with their partner. So what they described as kind of the stress was around they linked that with kind of role strain and role conflict with their partner. So there was a lot in the themes. There was kind of a lot of discussion around kind of loss of kind of their former life and activities and relaxation, and then I guess that space to kind of do the things they enjoy, but also that ongoing struggle to balance their different roles and responsibilities. You know, thinking about their new role as a dad, their role as a partner, and then often their role kind of sort of going to work and sort of maintaining, I guess, their the expectations at work as well. The men often sort of described feeling like a bit of a spare part in terms of some of their interactions with professionals. So feeling that obviously the feeling a bit, I guess, sort of excluded at times by maternity services, not being the focus, not being kind of included in discussions, not being kind of asked questions, you know, sort of getting their perspective. But sort of while feeling like the spare part, also in the descriptions from the interviews, sort of feeling like that was almost okay, and that they weren't being included because being conscious of I guess the resources within the NHS, and there not necessarily being enough resource to be able to kind of check in with dads as well. But also kind of not necessarily feeling that they deserve that or that they should be asked those questions, and a sense of just trying to get on with it, and using some of the typical things that they used to manage that period of maybe feeling more stressed and having poor mental health. So things like using distraction and talking, spending time with friends, but a lot of it kind of was there's a bit of a theme around kind of denying their feelings, distracting themselves rather than kind of talking about how they were feeling. They did emphasize the need to support their partner and to really sort of try and protect that relationship with their partner while trying to navigate that new role as parents. Okay, so next slide, please. Before going on to thinking about our experience of working with dads and some of the things that the dads that have accessed our service, I'll just really briefly discuss kind of what supports are available to dads currently. The national picture is very, very mixed. So what's available in one area is not necessarily available in another area. So there is a real postcode lottery around what support is available for dads. We know that typically commissioning wise, perinatal mental health services don't typically directly support dads. So offer, you know, sort of have them on their caseloads and offer direct sort of assessment or intervention. However, we do know that most specialist parent-infant relationship services can support dads, but there isn't a parent-infant relationship service in every locality. I think what we're seeing is a bit more of an acknowledgement around the importance of supporting dads, because dads are more involved in their children's lives than ever before. So we want to support them to be able to support their child well, to support their partner, to support the whole family. So there are things like, we've seen recently, there's a documentary on the BBC called Forgotten Young Dads. And if you haven't seen that, it's definitely worth a watch, to kind of look at how these young dads are trying to break down some of the stigma around accessing support, you know, sort of having that really key relationship in their child's life. There's the Dad's Pad, which is an app which was developed with dads by the NHS, which kind of goes through, sort of helps dads to kind of learn the role, you know, to learn the ropes, kind of skill development, sort of psychoeducation on there. There's Dad's Matters, which if your area has a Home Start service, they will often have, Dad's Matters will have sort of peer support groups, things like that. But they're also very active on social media. So they're definitely worth sort of following and kind of signposting dads towards Dad's Matters. The Pandas Foundation, they offer support to dads also in the perinatal period. Again, some of that is locality specific, but they do offer sort of a nationwide helpline, tech support, things like that. So and there's been a recent announcement around NHS England planning to add fathers and second partners to babies' health records from December 25. So I think that is a step in the right direction. It'll be interesting to see how that plans out and the impact that has on service provision. In terms of local support in North East Lincolnshire, so our service, we can support dads, and at the minute, so far we are quite a new service. About 20% of the parents open to our service are dads. What we found in terms of our service valuation is that there is no difference when they come into service in terms of those where they're at in terms of their mental health and that parent-infant relationship. So in terms of those kind of screening measures, they were seeing very similar kind of indicators of depression, anxiety, and difficulties in that sort of early parent-infant relationship. And equally, what we're finding is that at the end of our interventions, that they're responding just as well to those interventions as mums. Locally, we also have started the antenatal education offer is happening. Got different offers, but there is an offer sort of at the weekends and in evenings to support dads being able to access those in terms of working around shift patterns, work patterns. And there is a group called Dads United that do amazing work with dads in North East Lincolnshire, and the SANS charity also have a dads group for families who've experienced baby loss. I'm going to hand over now to Emma, who's going to talk through some of the kind of show one dad story called Ben, about how he's navigated you know, sort of fatherhood and the support he's received from our service. And she's also going to talk about some of the co-production work that we've been doing with dads.
Morning everybody, thank you Marianne. So I'm the specialist parent-infant relationship nurse within the team. I really enjoy the work that we're able to do with dads, and as Marianne mentioned, we know that dads are often overlooked within the perinatal and early years services, but we also know that their mental health and emotional availability will influence their infant's development so much. So as a service, we try to proactively engage dads from the very beginning when we can. We validate their experiences, their emotions, and we listen to their concerns. And what we do is create a space for them to reflect on their bond with a baby. We try really hard to support both parents as equal partners in that baby's life. And we know that when dads do feel included, the whole family will benefit from that. So I'm now going to share a short video of one of our lovely dads. So this is Ben, and Ben accessed our service from when Teddy James was just a few weeks old. As a family, they were both offered, mum and dad, lots of our interventions. Ben was recently discharged, and it was so lovely to see just how much more confident he was as a dad, and his outcome measures and goal-based outcomes had improved at discharge from when he first came into our service. So please, can we play Ben's story?
I think what's been really interesting is that the mums, and this has happened to me a couple of times, the mums have been referred into our service because they're struggling and they've come in for assessment, and then the dads are present to support the mum in their assessment. Actually, there's been some light bulb moments for the dads too, where they actually think, actually, I'm really struggling too, and I could really benefit from some support and some help here. And I think realising that, you know, we're coming in with that non-judgmental approach in terms of helping them and supporting them as a family makes them realise, actually, I will benefit from this work too.
My wife originally came in. She was struggling with a few bits, but we didn't know quite what. So she came along with mum. She came home and said, look, I've gone to this today with mum. I feel like it's going to be beneficial for me and for Teddy. I was like, right, okay. She then had her first initial appointment, and she then came home and said, it could support us all as a family. Would you be willing to kind of join me? So naturally, I joined her on the journey in order to support her as a family unit. So we went along, and then I've been brought into Growing Well to support Teddy as a dad, because I've seen things and support they could offer me. It's video log of, and it captures phases of connections with you. It's the VIX, that's what it was. So in the back of my phone, I keep a picture of what I received, and it's the direct eye contact between me and Teddy. You can see that natural connection and ability there. So my questions were, I wasn't sure if there was any of that natural ability there. When they showed me that reassurance, it was there. It showed me on the bad days of what a good dad I actually am, and it's that daily reminder of going back to that and seeing that photo where it's like, you're the best dad in the world. You really are. You just need to believe that.
Thank you. Oh, I really enjoy watching that video of Ben, because I just think it highlights how important dads are within the work that we do. Next slide, please. So we did some co-production, which is still ongoing work with our dads. And the three themes that have come out through that again and again were confidence, judgment, and connection. So number one theme was confidence at building a bond with the baby. Some of the dads reflected that they had struggled to connect until baby was actually born. So if we go to that next slide of the confidence, so until she popped out and was here, I wasn't as emotionally connected, but my baby adores me now, and I adore my baby. And they discussed how the relationship had developed through physical play. She comes, jumps on me, gives me kisses and hugs, and makes me feel good. It's a close relationship. And some of the dads told us that they'd often second express themselves. They wanted to do the right thing, but not always sure what that looked like in the early days, and sometimes took a step back for fear of looking inadequate. The second theme was judgment. On the next slide, please. So one dad shared that they'd noticed a societal expectation that men can't and don't talk, but shared his view that if you put them together, they would. One of the dads reported that they didn't feel that they could talk about their experiences to other clinicians and found having a male practitioner really helpful. I just wanted to speak to a guy about it. It was never really talked about, the impact on dads. And again, dads spoke about feeling watched, evaluated, and sometimes compared by professionals, family, and even strangers, for instance, in family hubs. So through this co-production work, we are hearing loud and clear that creating that non-judgmental space is absolutely essential. A space where dads can be honest, vulnerable, and human, let's face it. So our third theme is connection. And dads agreed that they would really benefit from a group exclusively for dads. I feel like if there was a dads only session and the kids were around the same stage-ish, they would be able to do more with one another and the kids could play better, and it would be good for dads to talk. The dads who were interviewed agreed that the timings and the location were really important to consider for the success of any potential group work. It would have to be a longer group so that dads would have that early part to decompress. One dad highlighting the need for a night or day for dads to come and join activities like a taster session. So the three themes, confidence, judgment and connection, are not just feedback. We are now obviously using them as our guide, and they will help to shape the way that we design our service, deliver our support, and make sure that the parents, particularly including the dads, are feeling that they are seen, heard, and absolutely held in mind. So if we just go to my last slide, please. So it wasn't really until she started walking around and blabbering more that I felt more connected. Getting the bond was a challenge. I felt very emotionally disconnected and struggled, recognising that I had a bond with my baby. I've always struggled with change. It was a bigger struggle because I was new into my career. It was something I'd built my entire life around, but my baby was always going to be important. Until she popped out and was here, I wasn't as emotionally connected. But my baby adores me now, and I adore my baby. And I think all of those absolutely speak volumes that this work is crucial to the future of infant mental health. Back over to Marion. Thank you very much.
Thanks, Emma. So this is our final slide. If we can just move on to the next slide, please. So I guess in terms of through some of that co-production work, which is ongoing, and these are some of the things that we really want to focus on in terms of that support that we offer dads. Also, we want, to support the system in terms of being, identifying dads for referral. Although 20%, actually I think is pretty good for quite a new service in terms of, those dads that are accessing our service, we would like to see that percentage increase. We would, really like to be able to offer some sort of group that's specific for dads. So, because what we're seeing in our work is that we're often offering support on a one-to-one sort of basis with dads. Not always. We have had dads access circular security group. We've had dads access our sort of ground play group. But because of working hours, shift patterns, things like that, and we're often kind of having to offer that support on a one-to-one basis. So to be able to sort of offer something that was group based, where they can sort of connect with other dads, would be really is something that's really important that we want to develop, and potentially sort of do that in collaboration with other parts of the system. I guess a goal for us is that we want dads to feel as comfortable and confident in terms of meeting their baby's needs, and not just their physical needs, but also their emotional needs. We would like to see dads being supported at all levels of the system. So obviously we're a specialist service, but what we would love to see is to try and sort of influence the rest of the system within our area, to really be really thinking about including dads in discussions, kind of checking in with dads, because we know that, I think the research is really clear, and we see it in clinical practice as well, is that actually, you know, supporting dads supports that whole family. So if we're going to work and support families, dads absolutely need to be included in that. It's really, really important. And it's, you know, it ultimately, in terms of thinking about infant mental health and development, it's crucial. So I think that sort of covers it. And so yeah, I guess the message from us is, you know, we really value being able to offer that support to dads, and I think we feel really privileged to be able to do that. But we're also seeing kind of the fruit of that and how important that is for babies and families overall. And our last slide just has details about our service, how to contact us if you've got any additional questions. Thank you.
Brilliant. Thank you, Marion and Emma. Fantastic. And it's really good to hear about dads as well, because sometimes we do, you're right, as you started off, sometimes not overlook them, but they don't get as much of that correspond that conversation as mums. So really great. And I'm sure we have got some questions, but please do put some questions in. We're running a little bit late, but I'm going to jig the agenda around a little bit, which is my one as chair. So bear with us. We will send the slides out as well. So but please do put some questions in. We're just going to have a bit of a video now, just to look at some lived experience. So I think it's so important that we listen to and see the video. So we will play. It will take us a little bit over time, but we'll do some questions, and then we will still have a break, and then I may just miss our section for me, but we'll go to the national picture, but we'll see how it is. But let's listen to the video first. So thank you, Jonathan.
And what we see is often, you know, sort of parents and caregivers presenting with quite a lot of anxiety or low mood, and kind of really worrying about whether they're going to be a good enough parent. And I think it is quite common to sort of, for those, you know, for parents to have those kind of doubts and worries. But I think it's maybe something that we're not as good at talking about, but it is extremely common. And I think the other thing that is much more common than people realise is, you know, sort of parents and caregivers kind of struggling to bond with their baby as well. And I think people are really afraid to come out and, you know, talk about that, but it is extremely common, and that's what our service is all about. It's all about supporting parents and caregivers to kind of feel more confident in terms of kind of reading their baby's cues and being able to sort of attune to their baby, and to feel that connection between them and their baby. And that is just so important for that family's, you know, life ahead, and that baby's kind of future as well.
So when Lola was born, I had a lot of issues with bonding with her and not noticing the bond, and I just felt like I was a babysitter. I didn't have any feeling towards, like, as she's got older, it started like coming back with the not noticing the bond. And the best part of being a mother is noticing that bond and feeling the love. But as she's grown up and she develops more, it kind of got less and less. And I was like, I don't want to go back to when I wasn't feeling the bond with her, because that's just not, like, it's the most awfulest feeling ever. But the circle of security made a drastic change in, one, how I was when I was a kid and how I developed, and it made me also recognise a lot of stuff that Lola does.
So some of the things that I've noticed from working with families is especially when offering our Circle of Security programme. So this is just an 8-week programme that we can do typically in group. It works really well in group, but sometimes to fit a family's need, we might do it one-to-one or do it with a set of parents or caregivers. But this group has a really lovely way of helping parents learn how their baby's communicating, maybe what to expect as their baby gets older, turns into that child and that young child as well, and what they might be trying to get from them and how they might be trying to get their needs met. I think it's been really helpful for parents to reflect on, actually, when I was little, I did this, or oh, actually, I recognise that my child is climbing all over me and using a bit of a climbing frame, but actually what they're trying to do is get my attention and they really want to connect back to me.
It gives me a happy feeling, because not knowing that you're bonding with your kid, but your brain isn't allowing you to see that bond, is the worst feeling ever, because I thought I'd never feel a bond with her. It was never going to be there. But thanks to the perinatal mental health team and Growing Well Together, I am loving life with her. They do help, like, with your emotion side. Like, thanks to them, they got me help with therapy and stuff. Like, honestly, if I didn't have them, I wouldn't have ended up going through with therapy, because I was just too scared of them. But they like helped me realise that I was ready, and I did need to do it, and I was prepared for it, and I was strong. I've started making sure I have time in a day to sit down with her and play with her, because before I felt awkward, really, really awkward to sit down with her and play with her because it felt uncomfortable. But now, most of the day, I sit down and play with her, and she enjoys it and I enjoy it as well. She's more happier and she's more confident in coming to me. What you got? Oh, thank you.
I feel that we have really filled a gap that was missing for quite a long time. There are universal services out there in terms of health visiting, family hub, midwifery, etc. Where that next step up. The perinatal team within Navigo have done some absolutely fantastic work with mothers who have moderate to severe mental health difficulties within their pregnancy and up to baby being a year old. Unfortunately, the perinatal team are not able to work further than a year, and they're not able to work with dads either, which is something that our service has obviously been able to fill. I think what's been really interesting is that the mums, and this has happened to me a couple of times, the mums have been referred into our service because they're struggling and they've come in for assessment, and then the dads are present to support the mum in their assessment. Actually, there's been some light bulb moments for the dads too, where they actually think, actually, I'm really struggling too, and I could really benefit from some support and some help here. And I think realising that, you know, we're coming in with that non-judgmental approach in terms of helping them and supporting them as a family makes them realise, actually, I will benefit from this work too.
My wife originally came in. She was struggling with a few bits, but we didn't know quite what. So she came along with her mum. She came home and said, look, I've gone to this today with mum. I feel like it's going to be beneficial for me and for Teddy. I was like, right, okay. She then had her first initial appointment, and she then came home and said, it could support us all as a family. Would you be willing to kind of join me? So naturally, I've joined her on the journey in order to support her as a family unit. So we went along, and then I've been brought into Growing Well to support Teddy as a dad, because I've seen things and support they could offer me. It's video log of, and it captures phases of connections with you. It's a VIX, that's what it was. So in the back of my phone, I keep a picture of what I received, and it's the direct eye contact between me and Teddy. You can see that natural connection and ability there. So my questions were, I wasn't sure if there was any of that natural ability there when they showed me that reassurance it was there. It showed me on the bad days of what a good dad I actually am, and it's that daily reminder of going back to that and seeing that photo. It's like, you're the best dad in the world. You really are. You just need to believe that.
Because of other circumstances and other situations, how I was genuinely feeling about the pregnancy, which I thought I would have been reassured about, 4 months into it. It was just getting worse. So that's when I reached out to the perinatal mental health services, and they redirected me to the Growing Well team. Instantly, I had Emma and Sammy come to my house, and it was as though I had known them for ages. They reassured me, made me feel like my feelings were validated. They understood me a lot more than people in like my personal life would have. They made sure that they created like a personal plan based on me and who, my life and my circumstances and what works for me and what my triggers are and what would help me to create an attachment to my pregnancy and my baby. Because when Emma first saw me, I was like, just no soul, nothing, just carrying something inside me that I knew was growing, had no attachment whatsoever, crying constantly, being very upset. And, I remember Emma asking me, when you're crying, what do you think your baby is feeling? And, I broke down and instantly said, realised that, my baby must be sad too. I say to my pregnant ladies that I'm working with that little baby inside your tummy is currently in its first home, and that home needs to be a safe, secure place. Just as safe as when it's on the outside, it needs to feel safe right now on the inside. As crazy as it sounds, it was a bit of a breakthrough, even in the first meeting, just to know that it could only go upwards from there. And I've already been pregnant before. I've had a pregnancy where it was planned and I knew what I was doing. But this time around, I thought it would have been, walk in the park, and it wasn't. I went to a few courses that they were able to provide, which are absolutely life-changing. We were able to reconnect with our babies and how we are as mothers based on how we were brought up. And that was really enlightening because I've never ever touched upon that on myself personally. The other Emma, she definitely helped me with regards to how the baby is processing things, not just while being in my womb, but when I gave birth as well, how the baby is seeing things, hearing things, feeling things that you just don't think of, and made me feel so confident, completely opposite to what I thought I was feeling. Like, I genuinely thought I was not even going to be able to go through this. It was, as morbid as it sounds, I felt like it was me or the baby in that process. That's how bad it was. But the utter unconditional support that I received from everyone, making you, reassuring you that you can do this on your own if you have to, from the beginning to the end. They don't make you feel vulnerable. They don't make you feel like you're weak. They don't make you feel like, what you're going through is petty. It's massive. You're giving birth to a human being. And I think it gets highlighted quite a bit about the baby, but I have never ever experienced, even my first pregnancy, a process where the the mum to be is highlighted and what she's actually going through. It's so catered for you, and I don't know how they do it because there's so many women, and the friendships that you build on the way as well, the support you have. It's just you will never feel alone.
Thank you for that. Those stories really helpful. Put it into to context as well. I think lived experience videos are just so powerful. So thank you for that. I know we're overrunning quite substantially, but we are going to have 10 minutes for questions, and we will still have a break. So I think it's really important that we've got some questions coming in. And I did say at the beginning I wanted it to be interactive. So I do feel that I need to welcome back Claire, Emma and Mariam onto the screen so that we can just have a few questions. And as I say, we will answer some as we go through, but I think there's some good questions come in. So let's have a look and see what we've got. So thank you all for your presentations, fantastic. And those videos were really helpful. As I say, really put it into context, which is what we're about. So the first one came in a while ago. So I'm going to ask it first. And it came from Robert Gilbert, and he said, "Hi Claire, I'm a nursery nurse. I wish I'd had the job title of your colleagues in our team. This is really interesting as we don't as yet run a COS group. I was just wondering what advice you may think or might think would be useful to bear in mind from your experience of setting up your groups. Thank you."
Hi Robert, thanks for the question. And firstly, I'd say we spent a lot of time worrying about the content and our lack of confidence in the manual and the content, because it all makes sense and everybody talks in the group and the women want to talk. It's easy. The trick is it's the practical stuff, ensuring that your organisation is going to give you a room to provide a baby-friendly room that's safe, and commit to that same room for the 8 sessions, but also the technology. You need a smart screen really, and we were lucky that our digital team helped us get a snazzy projector and one of those screens. The first group we ran, we were showing the videos on a laptop screen. It wasn't working. I think the Navigo guys have probably got even more snazzier equipment than we have, but it's the things that make the group work. Not the content of the material, if you know what I mean. The practical stuff, that's the trick. Make sure you've got that set up first.
Okay, great advice, thank you. So one from Lynette Robinson: do you also accept parents who have adopted babies? I suppose that's for all, any of you really to do. Should we start with you, Claire, and then I don't know if Emma or Maria want to answer that as well.
The specialist perinatal mental health team, I can't think we've got a yes or no answer for that. I think it would be dependent on the situation. I'm not sure. We'd discuss and decide, I think.
Okay, thanks. Any observations from Emma and Mariam?
Absolutely, we do. We accept any primary caregiver, and quite early in our team, when we first developed as a service, we also worked really closely with a foster carer who had twins in her care from just around a week old. And we got a referral in from the health visitor for those babies and foster carers, and we did some pieces of work with her just to help her to sort of settle the babies and to get to understand what the baby, particularly one baby, was far more unsettled than the other one. So we did some work, and yeah, that was a really nice piece of work. So yeah, we accept referrals for anybody really if they're primary caregiver.
Perfect, thank you so much.
We've also had quite good uptake from foster carers in terms of our introduction to infant mental health training as well. So really good uptake there.
Thanks, Mariam. One from Katie Jones: what is the referral process during the antenatal period for partners? We get a lot of feedback that they need more preparation during the pregnancy. Emma, Mariam, do you want to take that one?
I mean, for us, we accept self-referrals. So on the sort of Navigo Growing All Together webpage, our self-referral forms on there. So partners can refer themselves on there, or any professional can make that referral antenatally. I think thus far, sort of initially, a lot of our referrals in terms of partners has come through the process of pretend, you know, we've gone to assess mum, you know what I mean, we've completed an assessment, and you know, we've met dad as part of that process, or partner as part of that process, and kind of asked them additional questions, and you know, it's so almost a bit of a self-referral, but we are starting to get more referrals through professionals as well, but yeah, so families can be referred you know, from conception onwards into the team. We're always happy to sort of speak to families over the phone if they're not quite sure. And I think that can be quite helpful because, you know, I guess it's thinking about making sure that, you know, rather than kind of sending in the referral, you know, so if we can have that conversation first, we can kind of ensure that, you know, people are getting the right level of support, and, you know, just trying to prevent any of that ping ponging of referrals around, if that makes sense. So
And we also do,
referrals.
sorry, Marion, we also do quite a lot of community events as well. So we've worked as part of the steering group for the last few months in terms of developing a new antenatal programme, Parent Craft, for our local families. Previously, it's only been running a 2-weekly programme. It's now gone to 5 weeks, and one whole session for an hour and a half is on parent-infant relationship, the importance of building that infant mental health, etc. So that's really great. So we work with the family first practitioner to do a whole session and obviously talk about our service, so then any mums or dads that are maybe struggling with that relationship could maybe have those, you know, light bulb moments and think, oh, this could be for me. We're also started recently, well, we've piloted the first Nest and Nurture Fair at Diana, Princess of Wales Hospital, which is midwifery services are doing that. So we were there with our stand and able to again talk to parents that are expecting a baby, and we've done lots of other bits and bobs in the family hub. So we try to get out there as much as possible and be present in the community. So yeah, I think that answers that one.
Thank you. Anything further you want to add about that, Claire? If not, I'll go on to a couple of other questions. Thank you. We've got lots of really positive comments which you'll be able to read in the chat box yourself around the video, the presentation, and everything else. And it was so I'll let you read that, and the offers, etc. And then we've just got a comment about the various dads who have been beyond that. So that's good. The next one is from Rebecca. How accessible are these sessions for parents with learning disabilities, and do any of the teams link in with learning disability teams? And I think that again came in for Emma and Marion, but I will ask Claire if she's got any comments to add as well. So learning disabilities, Emma, Marion?
Yeah, I mean, in terms of we certainly have some parents on our caseload with learning disabilities and other sort of neurodivergent presentations. I think all our sort of assessments and support offers are quite bespoke, so it's not obviously we do use so we also use circular security parenting, so we use some kind of structured programs, but then equally it's a bit of a sort of pick and mix in terms of when we sort of haven't done an assessment, kind of got a bit of a formulation understanding what the needs are, then we'll sort of think about with that family what we might be able to offer and what they'd like to offer. So I think I'm just thinking of a family in my caseload at the minute. So a 16-year-old who's very recently been diagnosed with a learning disability, and that learning disability was, I guess, we sort of highlighted what we were seeing, and sort of that we were sort of querying whether she's got a learning disability. So with that young person, I'm doing quite a lot of systemic work, so supporting the system to support this young person and her toddler. But also she's responded really well to VIG as well. So I think, and some of our, I guess, less sort of, you know, some of those more indirect sort of support. So kind of getting out and going to sort of supporting her to be able to access baby groups and things like that. I think probably circular security parenting could need adapting. However, I can think of one parent who has accessed circular security parenting in a group who's got certainly some learning difficulties, and coped really well and really benefited from that. Did you want to add anything there, Emma?
No, I was
Thank
thinking
you.
the same. I think we've got a really good link in with our LD team, and I certainly have put a couple of referrals in for assessment, and they've been really accommodating, which has really helped with the work that we're doing to kind of know yes or no, is there an issue? So yeah, just to say we do absolutely link in with them.
Okay,
Yeah.
thank you. Anything, Claire, you want to add on that?
Agree with Emma and Marion. People with learning disabilities can access the service and will adapt.
And that's the final question, and then we will have a break. So I do think people need to have a bit of a break. We've been going quite a long time. So I got to AJ question, which is how do we translate the evidence of positive effects for dads and outcomes for children's health and development into access to those services wherever you live, rather than postcode lottery? Rural areas seem to be very little offered, very little, and the access to the service and transport is not the best. So how do we extend that coverage and outcomes when the rurality gets in the way? So again, Emma and Marion, and then I'll ask Claire if there's anything you want to end with. Just succinct answers would be fab. Thank you, Emma and Marion.
Yeah, really difficult. I guess it's funding, isn't it? We've been really fortunate that our service was commissioned. The funding sort of came through the Start for Life funding, and that's how that money was funneled to create our service. So we've been really fortunate. I think local authorities will have opportunities to, we don't know what the pot of money is going to be, is my understanding, but we'll soon know, and we'll have opportunities to make decisions around how they invest that money. So obviously from our point of view, we're going to kind of champion parent-infant relationship services that are open to any primary caregiver, including dads. In terms of, again, quite lucky in Northeast Lincolnshire that the geography is relatively small, but we're not really office based. We're out and about all the time, and that's our service model, is to go see families where they feel most comfortable, where they're most likely to engage. So I think that needs building into any sort of service model to be able to support that engagement, really.
Thank you. Anything, Claire, you want to add?
No.
Okay, thank you. Thank you for everybody's questions, and thank you again, Claire, Emma, and Marion. Some fantastic work going on. It's really great to showcase them. We are running a little bit late, but don't worry, I will put it back. We will still finish at 1:30, and we will still hear from Tom fully and from Ruth fully. I think that's really important. What I'm going to do is I'm going to lose my section a little bit, because I think most people are probably aware of the collaborative, and I think that Tom and Ruth are more important to go over that collective. So I'll just do maybe one slide to give you a bit of an overview. But if we could break now and come back at 10 past for the national picture from Tom. So if we have 10 minutes break, try and come back for time. So come back on time. We will start at 10 past and then I'll do a very quick overview of the collaborative, and then we'll go into Tom's session. So 10-minute break, and I'll see you all shortly. Thank you. Thank you for all our presentations for this morning. Hello, welcome back everybody. Welcome back to our second part of our conference on foundations for advancing life, perinatal and infant mental health. I'm going to just cut my little presentation. It was only short anyway, quite short, because it'd be great to hear from Tom and from Ruth. I think that's really important. So we will send all the slides out. We'll give you a bit more of an overview. So obviously I've mentioned who I am. So if you go on to the slide that mentions a bit about our collaborative, that'd be really helpful. So our collaborative is a collection of partnerships of organisations which meet really regularly, but it's not just mental health services. So you'll see on the screen there that we've obviously heard from a lot of our partners today, Navigo, Humber, Foundation Trust, etc. But we also work really closely with the acute sectors in that of York and Scarborough and Hull and North Lincolnshire and Goole. And obviously exceptionally closely with our local authority colleagues. But what's really important are the links that we're developing and we'll continue to develop with the voluntary sector, be that in its widest guise. And we know that we've got more to do there, but we will continue to strive to do that. And there's a few mentioned on here, alongside the ones we've had more established relationships, such as Mind and the Warren Centre, who we do a lot of work with, but we'll continue to expand that. And even though the Integrated Care Board is going through significant changes under the new reorganisation, we are going to maintain a collaborative approach from an NHS provider point of view, but also, as I say, from that wider partnership point of view, which is really important, because the things we've spoken about today we couldn't do in isolation. We're not islands as organisations. We need to do that collectively together for what's best for our patients, the families and the communities, and we can only do that in an integrated way. So it is, we've mentioned about 5 sector collaboratives within the Integrated Care Board. They're all beginning to change in a little way as the ICB changes, and that includes the mental health one and the learning disability neurodiversity one, but we will be maintaining a collaborative approach. And it's about how we can develop what we call a core offer. So we have a core offer across the landscape of Humber and North Yorkshire, that hopefully starts to look at variation and how sometimes variation is needed, because the reality, we've already mentioned that this morning, we've got a very diverse demographic group, but we need to look at that variation and look at outcomes and output, so the so what question. So we want to work together to make things better for our patients, our service users, our community, as I've said, and that's collectively. We want to align ourselves to the long-term plan and the strategic commissioning. And I think because I sit on the board representing all providers, I think it's really important because it really helps us influence those conversations as well as a collective. So we've done a lot this year in relationship to achievements. We've got a very, very thriving clinical assembly. We've got a very thriving performance metrics are improving, and all that's within the annual report that is available. I'm sure Alison can put the link into the chat box, but we will send that out as well. So lots and lots, and I thank all my colleagues. I'm just part of a wider the wider network. So thank you for making that possible, and hopefully you've seen today just some of the showcasing and the work that we're doing that has come from that collective approach. So I'll leave that there for me, because as I say, you can have a look at the slide. You can ask any questions. Please do put them in the chat box and I will answer them. There will be a question and answer session after Tom's done his section, and I can pick up anything that you want in relationship to the collaborative, the Integrated Care Board, etc. But I'll pause there for me and I'll go on to the national picture and welcome Tom Carhill, who is the National Director for learning disability and autism and neurodiversity. But we know there's been changes in relationship to very unfortunate that Claire Murdoch left from that national director's post. So Tom is going to touch on a little bit around the mental health as well. So so thank you so much. Welcome, Tom. I think you're no stranger to our collaborative annual event. Tom's always, I can't believe we're on our 7th now, our 7th year. So Tom has been with us more or less from the start. So it gives me a great privilege and welcome to say hi, Tom, and over to you.
Thank you. Good afternoon. Good afternoon, everyone. Interesting. This is my fourth, but last one. As you know, many of you know, I stepped down at the end of the year to become chair of Nottingham Healthcare, and I'm looking forward to that. So I might see you in another guise. It says national picture. I'm going to quickly run through learning disabilities. I just want to give you a bit of an overview on what my take on NHSE at the moment and where learning disability sits, and then I've got a slide on mental health, and I don't do mental health necessarily. That's Gareth and Louise have been picking that up, but they've helpfully given me some data on that. So shall we go through the slides, if that's okay? So look, we have this vision, and I think now is probably an important time to have this vision so that NHSE can buy into it and sign up to it. Someone asked me recently, does NHSE still really think around learning disability? Well, they're going out for a new national director, mental health, learning disability, and neurodiverse conditions. It's still a priority. If you look in terms of what the multi-year planning shows, it's got SEND in there, it's got learning disability, it's got autism, and I'm pretty sure about that. And I think there is a conversation about, the multi-year planning isn't just about money and what it's got in the spending review. It's about the priorities of the NHS, and we know that Darcy picked it up as part of the 10-year plan. I'll say a little bit more on the 10-year plan in a second. So next slide, if we can. Thank you. You know all of this, and I think I would point to Leader as being somewhere where we've seen some positive movement. You're still hearing some terrible stories, not as many as I think we had in the last sort of 5-6 years, but you're still hearing people not accessing services, still dying younger. But we are seeing some shifts, particularly around avoidable causes of death, and people living slightly on average longer. But there's still more to do, and you obviously see the autism challenges as well, and we're seeing that across the board. So context is well known to us. I'll go to the next slide. So inequalities is something that we need to continue to work with. There's some really good stuff around annual health checks. Annual health checks plans are in the multi-year planning framework. Digital flag, really important that we keep that going. And Leader, we're doing a lot now on trying to how do we streamline Leader. Leader is staying. It's really, really important for families. But how do we streamline it? How do we work in a way that we actually spend more time on the front end, which is, I think, the development angle of that. But continue to, and a lot of the program was set up originally around Winterbourne, but actually there's 1.5 million people who've got a learning disability. If you add in autism, you talk about 2.5 million people. That's much more than those that are in hospital. So really important we do inequalities first. And the 10-year plan, I think, will offer an opportunity, particularly around neighbourhoods, if we grab it, and no doubt you will in your local communities. Next slide. This one is about autistic people. I was going to go back and say a little bit more, but let's stick with this autistic people. We know that the waiting list is in the 230 mark. If you're a child going onto a waiting list now, you could be waiting for anything to do 5 years. We were hopeful there would be some money. We've not seen any, but we're working with the minister on a development plan about what things we can do. That said, we have seen for the 2 months running that more referrals closed than new referrals. And that's the first time we've seen that. And that was really down to you guys, down to the teams, working firsthand, trying to find alternative ways, trying to move resources around, trying to move teams around. And we're seeing that. Now, that will not still get away with manage the waiting list, and it is a priority for us to work with that. We're also seeing, sadly, an increase in the numbers of young people and adults who are autistic going into hospital and autistic only. We have a 10% target reduction from last year. We'd done well, I think, at the beginning of the year, but didn't quite get there at the end of the year. And the beginning of this year, we're seeing an uptick. We're seeing really good work around learning disability, but I'll say more about that in a moment. But still something we have to do, because otherwise these autistic people become the long-term people in hospital, and we need to avoid that. We've just managed to do it with people with learning disability. Next slide. Mental health hospital community, a number of big ticket items here. Clearly, the numbers of people with learning disability now has reduced significantly, and admissions are down. That's really good. Numbers of autistic people, as I said, are up. We are working big time on the Mental Health Act and how we're going to manage to do that, and what does a good community services look like. On one side, we're working with the ministers and all that about when you would switch it on. Because we're very clear is that it does need resourcing, does need good community. But we're also working with you guys and ICBs across the country about what does good look like. So a lot happening around the hospital community, but some real good successes. And if you look at the rate of admission for people with learning disability now, it's really good compared to historically. Next slide. I'm going up pace, guys, so I hope you don't mind. I'll give you some time for questions. Quality of care and mental health settings, still a priority for us. Culture, really, really important. Restrictive practice, important. Hopes is something we continue to promote, although it's not an NHSE product, but it is something that we see that does help and does make changes. We do know that people will need to be in hospital from time to time. What we want to make sure is that they get the proper care, whether that's in the NHS or within the independent sector. Still very much part of our work. Next slide. So starting to look forward, well, the first thing I would say to you is if you ever look at the 10-year plan and then wonder how it was going to be implemented, just look at the new multi-year operating framework and the planning framework. It is really taking things forward. If you think about it, it's talking about the new operating structure. It's talking about government missions, and it's talking about new organisations. And bringing clarity to existing structures, whether it's ICBs, or regions. So that's moving pretty quickly. What we've got to see is about how the neighbourhood health will be the opportunity for mental health, for learning disability, and for autistic people. And that won't happen by chance. That'll happen by us being involved in their development, and you're involved in them locally. But it does present a real opportunity. It also brings this conversation into prevention and community work as opposed to hospitalisation. And we would, I know in mental health we've been doing that for years, but it's something we would want to follow through. SEND, we are working very much as part of, along with DFE and DHSC, will be all one eventually, on the SEND reform. And that SEND reform is back and forth, and you can see it. And I think if you follow the national narrative around it, which is on what families are saying, it's probably a fair reflection. Ministers want to go further, but they're getting a lot of kickback, particularly on the EHC plans. So we've got to see what that happens for us. Moving forward in terms of the backdrop, we've said about the blueprints for ICBs, regional teams, NHS operating framework, and we are moving forward with the new structure of NHSE. You'll have heard as ICBs, you'll have heard as well about the voluntary redundancy being pushed ahead. Now that will have significance for the learning disability and autism team and the mental health team. And I think one of the new responsibilities of the new director will be to bring how does all that reconfigured? What are the priorities, and how can we deliver what we've said in the multi-year plan? So there's got to be some work there. Next slide. So this is the mental health slide, which my colleagues want to just make sure that you've got a sight of. Clearly, the new approach to mental health and emerging strategy, increasing focus on productivity, demand and prevalence review due to be announced fairly soon, and that will cover mental health and neurodiversity. The multi-year planning framework, I think positive in one sense. Mental health support teams, schools, really positive, but what we will expect is systems not delivering 25-26 will need to have plans to recover that. We're also pleased that SDF funding for the SR period, so rather than going into baselines, it will stay with it will be SDF, and we can keep an eye on it and track it. Talking therapies, some concerns about recovery, and I think there's a 5 month month-on-month concern about delivery there. So I think you guys will know this, and you will need to pick this up. IPS really doing well, really pleased with this. So pleased that it's in the multi-year planning framework. Capital, we've got capital for one centre for mental health 24/7, one centre per place over the 3-year SR period. We've got capital and revenue for mental health emergency departments. This money is in UEC. It's in urgent emergency care, so not necessarily in the mental health portfolio, but it'll need to be driven as part of the 10-year plan. So we will need to keep an eye on this and manage this locally. And of course, delivery of the final year of the ICB 3-year model of care plans, which will focus elimination of out-of-area placements and no commissioning of locked rehab beds after 1st of March 27. There's still ongoing fundamental risks. We know this. Out-of-area treatments, assertive intensive outreach treatment improvements, and is there gaps there? Are we able to do this 24/7 across the country? And we recognise that this is an issue for ICBs and obviously us nationally. The 10-year plan, I think we see opportunities around digital solutions, whether that's the NHS app, whether that's outpatients, whether it's actually therapeutic interventions. But what we're trying to argue is that anything that's happening across the board on digital, we would want to make this accessible for people who've got mental health needs and indeed learning disability and autism. And productivity and outcomes measurement, a major focus of our work in the next 12 months. And this is something that will be linked into the demand and prevalence review. I think there's a view that mental health, really doesn't have the same, and learning disability same focus on productivity that maybe across the rest of the sector. I'm not sure I'd agree with that. I think if you see the work that's happening on autism, if you can see the work that's happening about keeping people out of hospital, I'm not sure I personally agree with that. But that's a personal comment. So that's a quick canter through learning disability national picture. And what it feels like from our side. But I'll take any questions, I think, if that's okay with you, Michelle.
Perfect. Thanks, Tom. That was really helpful. And just to sort of say, from a collaborative point of view, we're looking at all those priorities that Tom listed. Not just because the metrics and the performance, but because they're the right thing to do for our people, really. So we're looking to see how we can utilise that within the revenue that we had. And one of the things that we constantly do is try and protect the mental health and learning disability and neurodiversity monies. For mental health, learning disability and neurodiversity, it's becoming exceptionally difficult. And then what we'll look at is say, well, what are our local priorities as well? And we do look at those in relationship to health inequalities and our, as I say, our environment, because we've got coastal, rural, urban, affluent, semi-affluent, and extremely, extremely the other side of that as well. So we do tend to work in relationship to that, but it was just nice to get that national overview, Tom. So thank you for that. Right, let's have a look. First of all, I was asking a question about Harrogate. We do bits of Harrogate. So that's hopefully answered that one. So let's get down to the questions. The first one came from Jessica Savage. So is there a system to support those with undiagnosed learning disabilities as they do not qualify for support without formal diagnosis? The same applies for those who have multiple neurodivergent needs.
Are you talking about SEND? I'm assuming that's regarding.
I guess it's about SEND, yeah, because it's about the system for undiagnosed learning disabilities.
I think is that Jessica, because Jessica, what we're really trying to do is move away from diagnosis in neurodiversity and autism particularly, and ADHD as well. ADHD slightly differently. We've been arguing with the minister, particularly that there is treatment options there. We're trying. This is the overlapping conversation we're having with SEND, is that a lot of families just want the diagnosis, and then that gets them into another arena. What we're saying is we want to move earlier. We want to be able to identify and get support to people earlier on a needs-led. I'm not quite sure how that's going to work in reality, and how do we say that to parents, but it does mean a lot more reliance on training, education, getting into schools earlier, the Oliver McGowan training. I think that would be the philosophy rather than the diagnosis. I think there's an argument about the 230,000 people who are waiting. What are they actually waiting for, and what's happening while they're waiting? I think that's a moot point, Jessica, and something that will require discussion going forward. But I think a shift away from diagnosis is an important one, and it'll be one we need to follow.
Yeah, I agree with that. And obviously we're doing a lot of work on the neurodivergency at the moment, especially given the growing waiting list as well. So we will continue to work with partners on that. So another one from Jessica was around because obviously it's about perinatal mental health today. So perinatal postnatal period is an increased time of stress and distress for people, yet there is very little commissioned in relationship to services to support them, or recognise their need for support in relationship to neurodivergent, and to have their mental health and safety plans be developed. Will that change, do you think, Tom?
Sorry, I missed
Okay.
that. I was answering one, so just come back to me. I was reading Michelle. I was reading Katie's next, so sorry.
Oh, right, okay, yeah. I'm sorry, I've clubbed them together because Jessica answers another. So this is about perinatal, postnatal period, and that's obviously stress and stressful, but we have very little that's commissioned in relationship to that. As you know, Tom, you touched on it a little bit in the presentation, and recognising their needs if they're neurodivergent. Will that change in relationship to developing safety plans? Will it become, I think what we're saying is, will it become a bit more of an area that will be targeted in relationship to commissioning or not?
Yeah, I think we understand a lot more about autistic people and how mental health affects them, whether it's eating disorders. But what we're doing is working then with mental health and about how that we can make sure that the mental health pathway identifies this and supports people. Claire Dowling has been doing significant amount of work with that. So we know the impact. What we're not looking for is separate teams. We're looking for core mental health teams, core learning disability teams, to be able to look after the neurodivergent people. And that is the approach. I'm hoping that picks up what you're asking.
Yeah, that's good. The next one is from Wendy, which is about autism annual health checks. And they've obviously been rolled out as a priority. Learning disability health checks have also shown an improvement in success. So do you see that happening, or when will it happen for autistic people?
So I don't know the timetable rolling them out, but we have been doing the pilots. I think it'll probably go further. I think it'll go to be autistic people, learning disability and mental health. And I would see us joining all that up together as we move forward. So I don't have a time frame for that, but the mood music for me, as what I'm hearing in terms of all conversations, is about why are we doing inequality so in segments? Why don't we look at people with learning disability, autistic people, and people with mental health needs, and particularly SMI in the round? And I think that's where the direction of travel will go.
Okay, thank you. And sort of building on that one from Katie, was saying, what is the SEND reform likely to say to make a real difference to children and young people? So it's a whole conference there, but just a couple of headlines, Tom.
Yeah, so I'm speaking personally rather than where this started out. SEND was about mainstreaming and inclusion, and that's very much part of the plan. I've seen that back and forth in terms of how far and how radical they're going to be over that period. So, okay, I'm not quite sure until we see the white paper. We are certainly seeing support for PENS and schools particularly, but PENS and LSEC and the work around those, and seeing resources coming in as a part of the spending review. So that will include increase in staffing and particularly support for ICBs. but I don't know in terms of how it'll ultimately land. I think it's Katie that was asking that question. That's yet to be seen. I think if you'd seen where we started and then seen where we were going to go with EHCPs and they're going to get rid of them and they're going to do something different, all of that is moving around. But it is a top priority for this government. I think they're just nervous about what happened with benefits reform.
Yeah. And I agree, and thank you for that. I think that you can see the shift, can't you? That's helpful. So there's another one from Katie, which is, you touched on it a little bit, which is how do we ensure that we keep this on the agenda and at the forefront of our minds, especially with those that are setting national direction and continued commitment. I think you touched on a little bit about that, but how do we really, given everything that's happening around us, Tom, keep it actually in that forefront of what they're thinking?
Look, I think there is a concern that this falls off the radar. We're doing everything we can nationally. I think we've done reasonably successful on the planning, but I think it's all going to be about then building on that. How do we keep it at your level, Michelle, and particularly at region, and particularly the ICBs? How do we do it when planning around acute care and urgent care? How do we do it when we're planning around neighborhoods? And I think there's a conversation of moving away from money is, these are people who are already in your community. Are you making reasonable adjustments? So the digital app, are we doing enough around digital? Are we doing enough around reasonable adjustments for urgent care, people who are in those waiting lists? So, but it's going to require colleagues on the ground, and I think one of the concerns is that 50% of ICBs are losing. 50% of ICB staff is of real concern. People retiring, people taking voluntary redundancy. So I think it's a combination of things that we will need to continue to do this, and it'll be the same for mental health, I would say.
I agree. And I was going to add that, Tom, that I think that's mainly in part to the ICB and the work that we're doing and what I've said about that collaboration and how we keep that on the forefront of the strategic commissioning agenda as well, alongside the developing joint social care committees that are developing in our places. So I think it can't all be that central piece. I think we have got a real duty to continue to that, which obviously Katie is part of, and I think it's really important that we do that together from a national as well as a local perspective, and to some extent region as well, because they're going to have a growing influence as we get into the new reiteration of the NHS. So good, thank you. Jessica's asked about neurodivergent, not just autistic, has a strong genetic link. So where is the planning for those who are affected through generations, especially given the risk of CSA, mental health, child removal and suicide, etc.? So is there any thought, any planning in relationship to that genetic link piece?
No, I'm not saying there isn't. I'm not able to give any feedback now. I'm within the work around ADHD and particularly autism. There's lots of research in terms of how we can support families and individuals. I think you're going to see more of that coming forward, but I'm not able to respond to that specifically, and apologies for that. I don't have the detail. I think Claire Downing probably would help on the autism side, and clearly ADHD is certainly not as well embedded, although the task force report's out now.
Yeah, and I mean, again, I can add a bit of that because obviously I used to chair the Clinical Research Network, and one of the things that we wanted to do more. No, not much more. But one of the things that we wanted to do was move more into that research piece around neurodivergent, genetics, etc. But they take time. As you know, so I think there is a growing interest and appetite for that, and certainly the money, when it's filtered through from the national, we are beginning to move that from all just acute based activity into more mental health, primary care, etc. And mental health in the widest piece as well. So I think that'll take time, but I think, Jessica, there is that appetite now. There is lots of abbreviations being used. I'm not making any apologies for this next bit because I'm just going to read it out as it's listed. So is the DSM-5 being adjusted so that there is more reflective of AUDHD for female diagnosis? That's another one from Jessica. Tom, that was must for you.
Jessica, I'm not quite sure what the DSM-5 is, and you'll forgive me for that. and I assume you're talking about autism, obviously. So I can't help with that.
No, I'm not sure. I can't either. Sorry, Jessica.
Jess, if you want to drop me a line separately, that's absolutely fine. Tom.Cahill1, and I can pick it up for you, and my colleagues in the autism team particularly can help.
Yeah, I was going to not give Tom's email address out. I was going to say, if you send it to us, we'll get it to
Fine.
Tom. But no, that's fine. No, that's fine, Tom. That's absolutely fine. And then you're going to final question. I think when we're talking about, was it send deliver? I think Jessica said it was perinatal mental health, but I think hopefully it's very similar, the response. So so the final question is, removal of diagnosis feels like it's likely to cause more people to be unable to access services, support, benefits and investment, particularly where it's actually a recognised disability. It doesn't feel like a proactive choice. It feels like it is likely to leave many people at a detriment, that it may make things cheaper for autistic. So I think there is a dual thing.
Look, I think it's a really good chat. And on one hand, you're right. I can talk to and point to conversations we've got with mothers, fathers, and those with lived experience who say somewhat the opposite. If I'd known what to do, if I'd got the support earlier, it wasn't all about diagnosis. That said, you can hear the argument the other side. Well, you know, if I'd known then about this and I had diagnosis, then I could go and get the support elsewhere. I think the jury's out. There is a shift about having to go through this big event to determine, and particularly if you're going to be waiting for years, as we know now, is there an alternative way? Can people get support earlier? Can they get advice earlier? Is there training out there for families? Is there training out there for staff working in different environments to help them understand neurodiversity and begin to provide reasonable adjustments in life? And I think the argument does hold to a point. Maybe it's both.
Right, thank you, Tom. That leads us into time. We're only a couple of minutes over now, which I think is good. So thank you very much, Tom, for your time, and thank you for picking up the mental health piece as well, because I know that's not your forte. And obviously, thank you for everything that you've done from a learning disability point of view. And I mean that in its widest sense, because I know that you've made some significant changes. And all the best for your future at Nottingham when you get there as chair.
Thank you, and keep going, guys. We will need to continue to shout about people with learning disability, neurodiversity, mental health, in whatever structures. I look forward to seeing you the other side. Thanks for today, and apologies for rushing. Cheers.
No, thank you.
Bye.
That's great. Bye. Thank you. Thanks to Tom. Okay, that brings us on to Professor Ruth McGovern, who is presenting an evaluation of intensive relationship-based intervention for pregnant women at risk of recurrent care proceedings. So Ruth is Professor of Public Health and Social Care and Population Health Services Institute at the University of Newcastle, and NAHR Population Health Centre Science Fellow. So thank you so much for coming to meet with us and share your presentation, Ruth, this afternoon. It's over to you.
Thank you very much, Michelle, and thank you for your introduction. It kind of saves me the job of this first slide, which was to introduce myself, but perhaps just by way slightly more of an introduction. What I'll say is that all my research really focuses upon the development and evaluation of interventions for disadvantaged children and families. And I'm particularly interested in this population and finding ways of supporting the population who are at risk of children entering care, or where children have already entered care, both in terms of supporting the mental health well-being of the parent, of the child, and perhaps where it's safe to do so, reunifying that family. Next slide, please. Okay, so what's the problem? This is a population very similar, actually, to the population that Dr. Keynes highlighted in his excellent, but frankly quite difficult to hear presentation this morning. Over the past 2 decades, there has been a year-on-year increase in the number of children being taken into care, including the number of babies being born into care. Around 1 in 4 mothers who experience child removal will return as a respondent in successive care proceedings. And the majority of these mothers who do experience recurrent care proceedings have experienced multiple disadvantages throughout their lives. Many have experienced substantial adversity in their childhoods, which has led to them becoming looked after themselves as children, and they are typically exposed to additional risk factors in their adult life, such as domestic violence, such as substance use, and of course mental health problems. They are also considerably younger at the time of their first birth than both the general population of mothers and also those mothers who experience a single care proceeding. And over the past decade, we've seen a rapid growth in services for mothers at risk of recurrent care proceedings, which is great and really encouraging to see. However, these services are often really insecurely funded, and there remains a paucity of research evidence for interventions, both in terms of whether they actually prevent children being taken into care, and also whether they lead in better mental health and wellbeing outcomes for mothers. Next slide, please. So I'd like to talk to you today about an evaluation that my team and I conducted on a service that was called the Startwell service, which until recently was provided by Bernardo's within 6 local authorities within the North East area. The service provided intensive relationship-based support to pregnant mothers who had previously had one or more child removed from their care and where there was a risk of care proceedings following the birth of their infant. Support started from the earliest possible opportunity following pregnancy being confirmed and intended to continue for around about 1 year after birth, irrespective of whether the infant remains with the mother. And in this study, we employed what's known as a realist approach to examine that Startwell intervention. Now, realist methodology starts with the assumption that no intervention works for everybody all of the time, and therefore traditional evaluations which apply binary questions of effectiveness, i.e. does it work or not, are largely rejected by this approach. Instead, realist methodology aims to unpack and explain the possible causal and contextual factors of change, to explain instead what works for who, under what circumstance and why. And it uses the formula of context plus mechanism equals outcome. So whilst a mechanism is how and why an intervention has an effect, the context is the feature that is perceived to result in that mechanism being activated or not. It is therefore ideally suited to examining complex social interventions whose influence is context dependent. And I appreciate that's quite a heavy a heavy lump of information there. I'll come back to it as I share the findings of the study. So realist evaluation essentially takes a theory-driven approach, and it iteratively seeks to develop, to test, to refine what is referred to as a programme theory. And a programme theory is basically an idea about how an intervention provides and leads to its intended or its observed outcomes. Within this particular evaluation, we conducted regular stakeholder engagement throughout the process, both with mothers and practitioners. We also used routinely collected child protection data relating to the 79 mothers and their infants who received the Startwell intervention. And using quasi-experimental methods, we compared these to 80 mothers and their infants from a comparison site who didn't offer the Startwell intervention, but where the mothers within the study would have received that intervention if it had been available within that local authority. So that they were also mothers who'd had at least one child removed who were pregnant, and there was a concern about child removal at birth. In addition, we conducted 39 interviews. 17 of those were with mothers who'd received that service. We also interviewed one partner. We tried to interview more. The service didn't really engage very well, or very often, I should say, not very well. They rarely engage with partners, but we did interview one partner who was involved in the service. And the remaining interviews were the Startwell practitioners themselves, social workers who were responsible for the case, and also midwives. And we synthesised this evidence to provide or produce our programme theories. Next slide, please. Okay, so what did we find out from all of this? We found that the Start Well service increased the visibility of these mothers, which really promoted accurate assessment and ultimately timely and appropriate safeguarding measures. Our quantitative analysis in that routine data that I mentioned found that babies born to mothers who'd received the Start Well intervention were actually twice as likely to be born into care. Similarly, those mothers who had engaged with the Start Well worker for longer, so we defined that as being for over 12 weeks before birth, were also twice as likely to have their babies born into care. And this was counterintuitive to what we were expecting to find. Now, within a traditional outcome evaluation, we would have perhaps stopped there and concluded that the Start Well intervention was simply not effective at preventing care entry. However, because we were using a realist evaluation, what we did instead was we really tried to engage with that complexity and really look at what's happening within that black box of the intervention. That's the strength of this particular methodology. Now, it's also usual within realist methodology to draw upon established theory when developing that programme theory about what your idea about how the things work. And within this particular evaluation, we drew heavily upon sociological theories relating to surveillance and also stigma, particularly when analysing that interview data and developing our programme theories. Could you just move on one, please? Thank you. Within this very threatening context of child removal, we found that that mothers were really highly distrusting of services. They perceived services to be adversarial, and that services framed their needs as risks that they posed to their child. And this led to mothers choosing not to disclose their needs or attempting to remain completely hidden from services altogether through not accessing services. However, what we found was that the Start Well practitioner focused very much upon the mother and her needs. And mothers experienced the practitioner to be compassionate and empathic, and resulted in women feeling understood and their needs validated. And we've heard today about, again, it was in Dr. Keynes' presentation about the value of the voluntary sector and how there's certain people who seem to connect and engage mothers who have lots of barriers to engagement. They seem to do a better job of that. And I think that's what we really saw very acutely within this particular evaluation. However, the Start Well practitioner focused upon her, the gradually contributed to the mothers lowering their defences and building a lot of trust and doing that engagement work with the service. As a result, mothers were more likely to have these open conversations about their situation with their Start Well worker. And this really led to mothers starting to attend services that they'd not engaged with before, such as antenatal appointments, the drug services, domestic violence services, and really becoming much more visible to services, much more visible to the child protection team, and therefore really alerting the teams to the risks that were present for the mother and also for our infant once born. And given the complexity of the needs of these women, the increased visibility of their needs, coupled with the size of the recovery challenge that was in front of these women, often did result in a decision to remove babies at birth. It was seen to be unrealistic to expect the mothers to be able to make the change that was necessary prior to the birth of the baby to alleviate that concern. However, whilst babies whose mothers were who received the Start Well intervention were more likely to be born into care, they were also less likely to be in care at 12 months. And we found that the Start Well service was able to utilise, the practitioner was able to utilise the relationship with the mother to support her to reduce risk over time. In particular, we found that following infant removal, the relationship between the mother and the Start Well worker was able to sustain We initially examined this quantitatively, as being born into care was highly predictive of being in care at 12 months. We saw mothers who had a baby born into care were 10 times as likely to still have their care, the baby in care at 12 months. We also found that receiving Startwell was predictive of being born into care. We therefore combined these two variables into one, and compared those against not being born into care and not receiving Startwell. So that became the new comparison group because of the fact that we knew these things were highly predictive. And when we did that, what we found was that mothers whose babies were born into care, but who did not receive the Startwell intervention, so the comparison site mothers, were 15 times as likely to have their baby in local authority care at 12 months compared to mothers who babies weren't born in care and didn't receive the Startwell intervention. Whilst babies who were born into care and whose mothers did receive the Startwell intervention were 4 times as likely to be in care. So you see that real reduction, and you see the a bit of a double negative here, a less bad outcome for those particular mothers. Can you move forward again, please? Thank you. We theorised that the Startwell workers were able to utilise that really safe and open relationship that they had with the mothers to provide, to communicate really hard to hear messages. For example, the need for the mother to end a violent relationship. These messages were often delivered best and received through repeat discussion, this intensive relationship that we found between this particular worker and these mothers, and really providing the opportunity for gradual and deepening reflection. So finally, grief and loss. The removal of a child, particularly in the early days of life, is clearly a highly distressing experience for mothers, and grief and loss was highlighted throughout all of our interviews and stakeholder consultation. Whilst the experience of loss in these circumstances is, of course, largely unavoidable, the process itself was thought to be a very difficult process and served to further induce those feelings of shame, stigma and distress. And perhaps is some of what is behind some of those shocking statistics that Dr. Kane shared. Many of the services that have been involved with mothers during pregnancy or whilst the baby is in the mother's care no longer have a legitimate role, and services are often withdrawn at that point. Conversely, mothers themselves might withdraw from services, particularly when relationships are negatively affected following child removal. In these situations, women are left with their grief, and this creates an even more difficult context for future pregnancy. Startwell was really distinct from these other services because it continued to have a legitimate role in supporting mothers irrespective of the care status. And we've already heard about how they were able to sustain a relationship despite the distress that the mother was experiencing, and perhaps some of the deflection of that towards services. And really, mothers took a lot of comfort in this particular relationship. Could I ask you to move forward once more? Importantly, the Startwell worker was able to support the mother to participate in activities, excuse me, such as having time with their baby after birth and prior to removal, to contribute to life story books, and also to decision making where appropriate around the baby's future care. These activities were reported to really serve to recognise the identity of the woman as a mother still and validate her grief and loss, whilst also providing the mother with a really important opportunity to be able to reconstruct their parenting identity and perhaps recognise that care might be what in the best interests of their child, and supporting that might become their way of also making sure that their child had the best opportunities in caring from them. Move forward, please. Okay, so what does this all mean? Well, our findings point to the benefit of providing support separate from safeguarding. So really the person who is delivering the support for the mother needs to be somebody who's not also assessing risk and assessing deficit within the parent. We think that this approach may enable mothers to experience a level of safety, excuse me, and trust that's necessary for her to allow her needs to become visible. This visibility is likely to be important for accurate and decisive action, meaning that where care entry is in the best interests of the infant, this can happen and happen without delay. We also think that by enabling the mother to allow her needs to be visible, the approach may be more trauma-informed, maybe more necessary, and make a necessary step to supporting the mother to retain care of her infants. As without the mother's needs being visible, it will be very difficult for her to work towards the change that is required for her from her within the child protection plan. We think that this approach fosters relationships between the practitioner and the mother that are able to sustain infant removal, and that was very unique in those mothers' experiences. You know, they'd previously been through removal before, all of the women in our study, and they often reflected upon just how dramatically different that experience was in comparison to the previous one. And because that relationship is able to sustain, this approach may really offer the optimum opportunity for mothers to work towards reunification. So it might not prevent care entry altogether, but care entry might prevent care entry in the longer term. And finally, where reunification is not considered in the best interests of the child, this relationship provides mothers with the critical support for their own well-being, whilst also we also wondered about whether a mother who received post-removal support may enter future pregnancies with less vulnerability to recurrence than she may have otherwise. But in this particular study, our follow-up was only 12 months, so this didn't allow us to really examine how many mothers became pregnant again and what the rates were for subsequent quick care entry. We do have, however, some plans about trying to build upon this particular study. You know, what I presented today was a rigorous evaluation. It was based on some good evidence, but ultimately, you know, we were looking at one service in one area of the country, and we weren't comparing. We're comparing it to routine child protection social work. Lots of the local authorities around the country are starting to bring these services in house. They're starting to have pre-birth social work teams, certainly in the northeast, where I live and work. We have the prevalent model is specialist pre-birth social work teams who are doing a lot more work around the support of parents. I guess one of the things we really want to learn is whether the kind of things that we've seen here would stand up to evaluation comparison to more specialist models, and really perhaps then give either support to our theory that we need to separate out these functions of support from safeguarding, or perhaps even challenge those and suggest that, you know, that was one way of working within this particular study, but other ways of working might equally be valid. We've got a study that is currently under review with the NIHR, and we're going to try and do exactly that. We're looking at evaluating pre-birth support across the country. We're hoping to compare a model very similar to the Startwell model that's offered elsewhere in the country, where you've got that real separation of support and safeguarding. You know, a voluntary sector organisation is usually providing the support. They're doing it with a big focus upon the mothers, without the same level of, we all have responsibility for child protection, of course, but without the same level of focus, responsibility for assessing risk, assessing deficit in the parenting. We're hoping to compare that against those pre-birth support models, but also looking at some of the models that are a bit more similar to the ones that we've heard about today, where you've got that really kind of multi-agency model around the family, with, you know, with the parent and the child's interests at heart, and configuring support in a multi-agency team. If that study is funded, that will allow us to really do some very rigorous research to compare them different models and really test some of the findings from this particular evaluation in a way that hopefully will give us some really clear findings about how best to configure support around mothers who experience these challenges in pregnancy and early parenting. in order to benefit their mental health, but also to prevent care entry. Okay, and that's me. I mean, move forward one more time, I guess, to see this final slide, just to thank you for the invitation to come along and chat today. And yeah, really happy to answer any questions that colleagues may have.
Thank you, Professor McGovern. Really great work. And I think Marion sums it up really well for me, which is really important work and insight. So thank you for that. And there's a lot there. Even though you were saying it's in one particular area. So before I got to some of the questions, there were other things that were sticking out in my mind as you were talking, and this may not be applicable, but I just wondered how we could maybe look at doing some of the similarities, not completely obviously, but where the role of the health visitor, because we're looking at the role of the health visitor particularly in looking at different things, like they just started to immunise in relation to measles, but they're there as a universal service. So I'm not saying it's to replace, but is there something that you feel we could maybe look at? I don't know, you may say no, but I just because obviously I am a health visitor as well, so there's a little bit of residing with me a little bit. But any thoughts on that?
I would say yes, actually. I mean, one of the values of realist methodology is that you do produce something that is at a level of abstraction that can be tested, and I guess the principles can be applied in different places. So I actually think that there is a lot that we can learn from this study for all sorts of different professionals. And perhaps what I'll mention specifically in relation to that is, beyond this study, another one that I didn't mention today was we were funded to do an evidence synthesis by NIHR to look at the international literature in supporting the mental health and well-being of mothers at risk of recurrent care proceedings. What we've done through that is look at lots of different literature right the way through the pathway, from pregnancy all the way through to permanency outside of the family and what support is needed in between. And again, we're using a realist methodology to that. What we plan to do in that particular study is take our findings to colleagues within the health and social care system and do some kind of system mapping work and really look at, this is the principles, what we've learned, this is what the literature tells us is really important to do. Now let's look at the pathway that these mothers go through and what would we need to do at different points in the pathway, such as the health visitor, to apply these principles and apply this learning. And I think, I mean, to go back to your question, sorry to give the long road into the answer there, but to go back to your question about this particular study and how this could be informed, I think one of the things that we really learned from this is that, I mean, we talk about the separation of safeguarding and support, and what's beneath that is this sense that mothers have of being really surveilled and feeling very threatened in that context. And actually, by removing support away from safeguarding, it allows to have a bit of a bubble of safety. I think health visitors have a role equally, where you can have a very positive relationship and based on trust, recognizing just how challenging trusting services is for a group of women such as this, and really work towards focusing upon the mother's needs, as well as perhaps how that might relate to the infant's well-being. I think the focus that we get from social work, I see this as somebody who has a professional background in social work myself, is there's so much crisis intervention, there's so much assessment of risk, there's so much focus on deficit, that kind of integration of support and safeguarding can be really challenging. Other professionals with a more supportive role offer a real opportunity for this population, I think.
Okay, thank you. Steve might make some point, but I think it's useful to get your thoughts on this really, which was about all the presentations, and they have this, really common theme through, which is around our need to improve the whole family offer. So we've heard about dads and mums separate and then coming together, rather than just to focus on individual mental health needs, which we've got into a bit of a habit of doing, to be honest. And I think we're trying to integrate it more now. And then obviously that can add significant complexity and challenge, but it can also bring benefits as well. Have you got any thoughts on that whole family approach type thing?
Yeah, I mean, this is probably going to the literature review as opposed to this particular study, because as I mentioned, you know, all our interviews were with mothers. We'll have one partner, and that was a really positive interview. The father represented a real resource to that particular family in that particular circumstance. We had no extended family members in this particular study either. In the literature review, there is some evidence that actually where you can galvanise a support network around the mother, such as the family, that can be really helpful. If you're thinking about wider family, first of all, that thing about mothers experiencing shame and stigma, that's often felt within local communities, but it's also felt within family networks. And actually involving the wider family in conversations where the trauma that the mothers experienced, the challenges that they've had, are recognised and understood, can actually be really helpful in developing the support network within the family, because the family then begin to recognise the challenges that the mother has, and can also see themselves as being part of the resource and the solution. So that can be really positive. One of the challenges, however, with this particular population, both in terms of the fathers of the child and also the wider family network, is just how much complexity is often in those relationships. I mentioned in my introduction that many of these mothers were in care themselves as children, so they've got a trauma history that connects with the family, and often the support that they might need in a network isn't present in their families. We see really high levels of domestic violence in this population, so relationships can be particularly challenging. I think one of the things that is increasingly recognised, however, is that not involving men, fathers, partners in interventions because of that is actually a really bad way to go, because either it's in, you know, what you're doing is you're putting all the onus upon somebody who's a victim or a survivor to manage their abuse themselves, and particularly because of the, you know, a lot of the discourse around child removal does link to those challenging, conflictual, and sometimes really abusive and violent relationships. So you're putting too much onus on the person who's surviving the abuse to manage it and address it, and that creates a failure to protect discourse. But also, even if the partner is no longer the current partner, we know that some of these men go on to have other relationships, you know, other children are affected, so that really, you know, it's very necessary for both the current family context, but potentially future family context, to do some of that work in the immediate and the wider family network. So yeah.
Okay. I suppose it's a bit, I suppose a bit of left field, but I'm obviously when we talk about resources and context and things, and you may not have done, but we've obviously mentioned a lot around that trauma, which is absolutely key and very central. I'm not saying it's not. But did you look at any economic benefits in relationship to, because obviously we've done a lot of work about how it nurtures and encourages growth and development, etc. But was there any hard fact outcomes in relationship to any economic benefits from a cost point of view or from a financial point of view? I know sometimes it's hard to bring that in, but you've got to be quite realistic when we're dealing with what we're dealing with, making case, and when we're making cases to do things, it was just interesting.
Yeah. We really tried, Michelle. We really tried. We had a health economist on this particular evaluation who did some really great cost consequence work. The challenge that you've got in this very particular study is, as we've said, that the mothers who were in receipt of the Starwell intervention, their needs were much more visible. They were far more likely to have their babies taken into care at birth. So what we were basing our cost consequence analysis was the number of days in care, because of course care is very expensive. There are lots of other things going on with this population, lots of other services that may come into contact with the mother, certainly is needed in many cases, even if they don't come into contact with the mother, that we were unable to extend our cost analysis to. But even just focusing on care entry, the challenge that we had was because the babies came into care quickly, they were intended to be in care for a similar length of time because we only followed them up for 12 months. We believed that a lot of the babies that were in care at 12 months from the comparison group were still in care for quite some time, perhaps long term, but we didn't follow up long enough to get to the point of permanence. So in this study and as a result, the health economists could do very little with the data other than give some figures about, you know, if you perceive this service the prevention of care entry to be worth this much, this, you know, and just give the hard figure of how much the service actually cost. In the study we've got under review, we do have much longer follow-up rates, and hope that we can provide really tangible cost consequence data on that one. Perhaps if that study's funded, there might be a future opportunity for me to come to colleagues to chat about what we'll find there. But in the current study, I'm afraid not.
And I do much prefer the terminology cost comparison, and we'll be using that now because it's a lot better word to use. So thank you for that. Just a couple of questions before we do finish. So we've got such valuable research. True that birth mothers fall into this black hole once the baby is removed and services no longer available and appropriate. Great about the ongoing support through Startwell, some similarities with the Pause project, Pause creating space for change. But good to hear that Startwell is supportive during and after pregnancy removal. Anything you want to add about that? Which is that this is a comment, but I don't know if you wanted to say anything about Pause.
I wouldn't mind coming in for Pause if that's all right, because I think one of the things that I guess I really want to highlight, and that's something that we're looking at a lot in the evidence synthesis that I mentioned, is actually that thing about context. The thing about this particular study was we were examining an intervention that happened whilst the baby is still there. And that is a really difficult context to do work in. Many people on this call will be working with disadvantaged mothers, you know, during pregnancy or while baby's still in the care. It's because of all of that threat that's in that environment for that mother makes it really hard for them to be able to engage with and benefit from support. Pause is a really important intervention on that, you know, for a population very similar to this particular population. The difference there and why you need both is that the mothers who are in receipt of Pause do not have their child in their care, or certainly the child that is the index in this particular interaction. And as a result, the threat is really much lower in that environment, and it's in some respects, it's easier for the mothers to begin to work on the needs that they have, to be honest, to disclose, to engage with services. But the recovery challenge is huge at that point because clearly they have the current loss. So these are really important services, but they do really different things. And I just wanted to recognise the different ways in which they work.
Okay, brilliant, thank you. Final question from Katie Morley, which is about, are you linked in with the Maternal Mental Health Council's project in Newcastle and Gateshead?
The Maternal Mental Health Project in Gateshead, I don't think I am, because it's, unless I refer to it as a different thing. So if did you say it was Katie? If Katie is, and there's an opportunity for me to link in, I would love that. Please do reach out via Michelle and colleagues if that's something that I can contribute to.
Yeah, thanks, Katie. I'll put them back in the chat box, or as I say, if you let us have details, we'll send that on to Ruth. Okay, I'm going to finish there because we've got a couple of more slides, which is just to ask you what you thought about the conference before we finish. But thank you very much, Ruth, for your fantastic presentation today. It's so important. I think it rounds it off very well in relationship to how we've gone through and set the agenda out. So thank you so much, and please keep in touch, especially as the work develops. We'd be really interested to hear the outcomes of that. But thank you so much, really, really helpful. Okay, everybody, we've got 3 final slides just to finish. We're probably a little bit ahead of time now, but we wouldn't have been if we hadn't. I just mix the agenda up, which is, I'm sure people are used to using them now, but the 3 meta slides, which we want to the QR codes. If you scan the QR codes, we just see your feedback really. So we get a bit of live data, and then obviously anything you want to put in the question and answer box, then please do, or we will send you out a full evaluation. And don't forget, last year we asked you this, and it was around perinatal mental health, which is where we've got today. So we will try our best to try and accommodate it. While you're having a look at the QR code, thank you to everybody that's presented today. Dr. Cairns, we started with Claire, Emma, Marion, Tom, Ruth. I'm giving you that great picture of oversight in relation to public health, the importance of the whole child approach and the whole family approach, the bit about dads all the way through to the national picture and the changing national picture. I do think hopefully we've met the title, which is Foundations for Life and Advancing that Perinatal and Infant Mental Health, but do let us have your feedback. And as I say, we will send out the recording, we'll send out another evaluation piece. Please, they don't take long, it is important to do that. Can I thank everybody, Jonathan has been doing the slides, all the team that have worked on it today. And we will also send you out, which I said right at the very beginning, the annual report, which is a little bit more about us and a little bit more about the so what question and what we've achieved and what our challenges are going forward. But if we can have a look at the slide, the next couple of slides, that would be great, and let us have your feedback. So I'm going to hand it over to the team to do that while we get the slides up, and you can scan the code and then let us have your thoughts. So over to the team to do that. Should be appearing on the screen now.
Can you see me, everybody? It's Alison Flack.
No,
can
Alison,
we go?
Can you
hear me?
Yeah.
Okay, thank you. Thank you, everybody. So if you could just go to your scan the barcode, which hopefully will have took you to the Mentimeter. Could we put the first question up, please, Jonathan? Here we go. Okay, so thank you again on behalf of Michelle as well, and everybody who's put together the conference, for all of our speakers. It's been a fantastic morning. It's gone by so quickly, and it's been a really good range, I think, from the national picture from Tom, but also what's going on locally across Humber and North Yorkshire, and hopefully clinicians will be able to take some experiences and knowledge and stories and be able to link together as well. So the first question is, overall, please can you rate our conference? And there should hopefully be, I'm waiting for it to take me through to the next screen. Can we go through to the next screen, please? Here we go. Michelle's done her chairmanship skills really well to time, and then at the final minute we take all the time up for the Mentimeter. Right, here we go. Overall, please can you rate our conference? Poor, fair, good, very good, or excellent? So if colleagues could just please give us their responses, that would be really helpful. Hopefully we should start to see them appearing on the screen. It gives it a minute and the slide should come up with it. Okay, we are getting the responses. We're just waiting for them. Okay, can we move to the next question whilst we're waiting, please, Jonathan? So here we go. The quality of the speakers was good. So do people think that was strongly agree, neither agree nor disagree, or strongly disagree? If colleagues would take a minute just to respond to that question. It doesn't look like we can get the immediate responses. So if that is the case, we've just got one more question, and then we will give the feedback after this, just so that we're not having people waiting around and can hopefully get on and have their lunch. So hopefully, and here we are. Just can people just within the feedback give us an idea of what they'd like to hear about next year? So this year was about perinatal. It was around dementia care and our dementia strategy last year. So it'd be really helpful for when we're planning our 8th international conference, if people could just give us an idea of what they would like us to focus on. That would be really helpful. So what would you like to hear about next year?
Oh, ADHD, yeah.
So we're starting to see some results now. ADHD. It's quite difficult. Prevention, mental health, signposting. Mainly, here we go. More specific LD and pregnancy support, neurodiversity and waiting lists, children and families, neurodiversity. I think the neurodiversity seems to be coming out loud and clear then, and I think that would probably be a really good area to focus on next year, because I'd like to think that we'd made a significant amount of progress in the plans that we're delivering. So I think that one will probably be coming out as the top contender. It'll be interesting to see where we are next year with all of the changes in the medium-term plan and the 3 priorities. So thank you everybody for taking the time to do that, and then we will send it out, the full results with all of the slides. So I'll just hand back over to you, Michelle. Thank you.
No, thank you for that. And there's no surprise that, you know, diversity is coming out really, really high. And I suppose obviously we just had the recently published ADHD report as well. So we'll have a look at that and see how we can and what we think in relationship to neurodiversity. There's also some good suggestions on physical health and neighbourhoods and what have you. So we'll take all that away, plus obviously all the feedback, and we'll obviously send you out what that feedback is telling us, what we've done with that feedback, and what we're thinking about next year. And obviously, if anybody has put neurodiversity down and you're particularly wanting to maybe present or do some showcasing, then it's always better to have that little knowledge beforehand, before we actually set out everything that we can work with. But thank you to everybody. There's about 4 minutes left. I think the timing has gone absolutely fantastic. Thank you to everybody that's presented today. Thank you for your time as well, because a whole morning on a Monday morning in the middle of winter, I appreciate, is really difficult. So I hope that you found that very interesting. As I said, I think it's coming out that the people have, that you've taken something away, and we will look at some of the key themes that have come out today as well, and link those into our strategic development, and especially around the core offer, etc. So thank you to our speakers, thank you to you, thank you to everybody that's made it possible, and please have a really lovely afternoon. And thank you for everybody that does any work or work around, because don't forget, you will make a difference to people's lives on a day-to-day basis. And all those people, thank you so much.